Yeah, good, thanks. How are you?
Good, good.
We start on time. Yeah.
I will start, sir. Good evening, all. On behalf of Gopal Krishna Charitable Trust, I welcome you all for this 4 days conference titled 4th Annual International Review in GI Cancer. I request Dr. Tejinder and Dr. Advait to give the welcome address, please. Over to you, sir.
So I welcome you all to this 4th Annual International Review on GI Cancers. We are holding this meeting like last year because we are in the same COVID boat, all of us. And this is going to be a 4-day event running over 14th, 15th, and the 21st and 22nd of May. And we've been a very popular meeting, and this has been a premier meeting in the GI cancer space, and this actually provides a good forum where we discuss the enigmatic nature of GI cancers, and this is really backed with review of praxis changing publications in the scientific program, and there is a lot of shared exchange of knowledge that we discuss during these meetings to meet the challenges faced by oncologists in the treatment of this group of cancers. And we really look forward towards the active participation from all the faculty members. Thank you. Sarika, you can introduce.
Sarika, you can introduce. Yeah, the chairperson. I think you have to call.
Yes, yes. I think all the faculty and delegates who have taken their valuable time out to participate today. Without much delay, let me invite the chairperson for the first session. I invite Dr. Inan, Professor and Head, Upper GI Surgery Unit, Department of Surgery, CMC Hospital, Vellore. Dr. Inan, over to you, sir.
Thank you very much. At the outset, I'd like to thank the organizers for giving me this opportunity. And I would like to invite you all for this annual international review on GI cancer. So this first day is going to be on upper GI cancers. And the first session is going to be on gastric cancer primarily. So I would like to invite the first speaker, Dr. Harsh Kanare. Dr. Harsh is currently at working as the head of the upper GI surgical unit at the Royal Adelaide Hospital in Australia. He is a quite well-known figure, and he has visited our center in Vellore for quite some time. And in fact, one of our colleagues who was here is working with him now. So he is going to be talking on advances in surgery, in particularly minimally invasive surgery and optimal nodal dissection and organ sparing surgery. So over to you, Dr. Harsh.
Good evening. My name is Harsh Kanare. I'm head of upper GI surgery at the Royal Adelaide Hospital and senior consultant upper GI and HPB surgeon at the Queen Elizabeth Hospital and University of Adelaide, obviously in Adelaide, South Australia. These are the institutes of my affiliation, Royal Adelaide Hospital, Queen Elizabeth Hospital, and the University of Adelaide Medical School. I do not have any disclosures or conflicts of interest to declare. My remit today is to talk on gastric cancer with a particular emphasis on extent of lymphadenectomy, minimal invasive gastrectomies, advances in robotic gastrectomies. We'll do a bit of a comparison between robotic and laparoscopic techniques, and also newer technologies and advances. Start with a bit of a historical aspect. And as most of you know, a lot of work on gastric cancers has been done by the Japanese people, and the Japanese Gastric Cancer Association has been instrumental in devising a lot of definitions and techniques for gastric cancer resections. So initially in 1963, this was what the Japanese Gastric Cancer Association proposed: the stomach to be divided in 3 parts and 4 lymph node levels defined according to the location of the tumor and extension of the primary tumor. So stomach was divided into upper third, middle third, and lower third, and lymph node levels N0 to N4 according to location. The current concept has changed slightly. Many of you might recognize this diagram from the recent publication of the Japanese Cancer Guidelines. What we now describe is levels of lymph nodes going from level 1 to level 16. Most important for us are level 1 to level 12. The levels 1 to 6 are perigastric nodes. Level 7 is left gastric, level 8 is common hepatic, 9 celiac trunk, 10 is splenic hilum, which is not depicted in this diagram, 11 are along the splenic artery, and 12 is along the hepatoduodenal ligament. The colors and the circles in diagram indicate what level of nodes are resected for D1, D1 plus, and D2 dissection in gastric cancers. Gastric cancer surgery is tailored according to the location of the tumor, and proximal gastric cancers usually, especially in the Western countries, are treated with a total gastrectomy with the lymphadenectomy as shown in this picture. Whereas distal gastric cancers are treated with a subtotal gastrectomy, with the lymphadenectomy tailored to the location of the tumor. So mostly in a subtotal gastrectomy, we wouldn't remove level 2, level 11D lymph nodes, but would take the rest of the nodal basins. This is now fairly standardized all across the world. Proximal gastrectomy is another concept which is mostly utilized in Japan and Asian countries. We don't perform these operations very often. Having said that, we've done a couple of proximal gastrectomies just in the recent past at my institute. We mostly treat these cancers according to their location, either with a total gastrectomy or an esophageectomy. But again, the lymphadenectomy is tailored according to how the stomach is resected. The JGCA again defines the types of lymphadenectomy that are necessary based on the T stage of the tumor. And here we have the recommendations which go through D1, D1 plus, D2, and on the next slide, we'll go through D2 plus lymphadenectomies. I think it is fair to say that most of the cancers that we encounter in the Western world are T2 and above, and our lymphadenectomy is typically D1 plus to D2. We hardly ever do a D3 or a D2 plus lymphadenectomy, and we rarely, if ever, perform a D1 lymphadenectomy unless the operation's done for palliative reasons or a very early stage T1 cancer. Exceptional circumstances for D2 plus lymphadenectomies. This is really a non-standard operation in the West. There is no hard evidence to show any benefit of an extended lymphadenectomy like the D3 lymphadenectomy in gastric cancers. Historically, the D2 dissection actually involved removing the level 10 splenic hilar node along with a splenectomy. In other circumstances, such as tumor metastasis to level 6 nodes, some Japanese authors advocate doing a 14V lymph node resection, which is the SMV area lymph node. Number 13, which is a posterior pancreatic node, is rarely resected in our setting, and we hardly ever go to the number 16 para-aortic nodes. We actually consider these to be non-regional and metastatic disease. So in brief, in the West, the protocol that we follow is T1 and N0 tumors go straight to surgery, and most of the times we'll have either a subtotal or a total gastrectomy depending on the tumor location. For T2 and above tumors that have positive nodes or even negative nodes with no metastatic disease, the standard of practice is perioperative chemotherapy followed by surgery with a D1 plus or D2 lymphadenectomy. This is all stemmed from the MAGIC trial, which, as most of you will know, showed a significant improvement in 5-year survival with gastric cancers, going up from 23% to 36% in patients who were treated with perioperative chemotherapy. Based on these results, most of the Western world adopted this practice as being standard, and this is what we follow. Not so much the MAGIC protocol these days, but we've moved on to FLOT. We did a small study of our own patients here in Adelaide, and we found that our results with the use of neoadjuvant chemotherapy reflected those of the MAGIC trial. This study was done entirely on population who had MAGIC as their neoadjuvant chemotherapy, and the non-neoadjuvant chemotherapy patients were ones who were not eligible for chemotherapy because of comorbidities or age or other factors. So our survival was very similar to that in the MAGIC trial, about 23 to 24 months median survival in non-chemotherapy patients, and about 46% 5-year survival for chemotherapy patients. The standard of care at the moment in the Western countries is perioperative FLOT, which is a different regimen of chemotherapy. I won't delve into details of the chemotherapy trials, but essentially there has been further improvement by the use of FLOT over MAGIC in treatment of gastric cancers with a stage-wise comparison. So at the moment, this is what we use. Perioperative FLOT followed by surgery, but surgery still remains the cornerstone of treatment of gastric cancers, and lymphadenectomy as D1 plus or D2 has to be adopted. This is again our data in the same study with the same patients, which again goes to show that anyone who has positive lymph nodes has a much poorer prognosis with gastric cancers. The importance is, unless you do an appropriate lymphadenectomy and get optimum nodes for staging of gastric cancers, we're never going to get accurate staging, and hence the appropriate prognosis is not available if we don't do an adequate lymphadenectomy. So that not only is lymphadenectomy important in terms of treatment, but lymphadenectomy is important in terms of accurate staging of all gastric cancer patients. I'm just slightly going to deviate now and move on to the next topic in our talk today, and this is regarding organ preservation, especially preservation of omentum and preservation of the spleen during gastrectomies. There is new data that is coming up, and especially studies like this, which is a meta-analysis of retrospective studies, which goes to show that omentectomy is not necessarily always required in gastric cancer resections. This particular meta-analysis shows an equal survival at 72.9% and 70.3% for patients with and without omentectomy. Similar results in this Korean study, which was a propensity match study of a retrospective nature, nevertheless, again showing better survival for the non-omentectomy group with a shorter operating time. These studies do have a selection bias, and from reading between the lines, most of these are performed on early stage tumors, T1 and T2, and on tumors that are not close to the Greta curve of the stomach or not showing any serosal disease. So I think there is a role to preserve the omentum, especially in minimal access resections. And this is particularly true in tumors that are not invading over the serosa of the stomach, are less than 3 centimeters in size, and are not on the Greta curve of the stomach. So there is good retrospective data to suggest that the omentum can be preserved and the surgical time can be reduced. Splenectomy is no longer the standard of treatment in gastric cancers. We perform splenectomy only if the tumor is in the proximal stomach and involves the Greta curve of the stomach. It is extremely rare for someone to have a splenectomy for distal gastric cancer unless there is some kind of a splenic injury or problems arising during surgery. So preservation of spleen is really the norm in terms of gastrectomies at the moment. There are multiple studies that have been conducted both in Europe and in Japan, and both European and Japanese studies have confirmed that splenectomy is not necessary, increases morbidity, and does not add any benefit in terms of survival unless it is performed in special circumstances where the tumor is close by. So both Japan and the West have now adopted the approach of preserving the spleen unless it's necessary to remove it. Laparoscopic resections are fast becoming standard of care, so I'm just going to move on to the laparoscopic and minimal invasive aspect of gastrectomies. The Class 01 trial results are about to be published or are just being published. And these are exceptional results with 94.2 and 93% 5-year survival. Bear in mind the tumors here are only stage 1 cancers, T1N0 and T1N1. So the study, however, goes to show that minimal access gastrectomies are safe and do not impact on survival. If any, there is a bit of improvement in survival in the laparoscopic arm. Similar results replicated in the Japanese trials with fairly low anastomotic leak and morbidity rates. I'm just going to skim through the last couple of slides. I think we're still in infantile stages with robotic surgery, especially in the Western world with gastrectomies. We're not entirely sure that there is very robust data as yet that's available for robotic gastrectomies. There are some studies, mostly retrospective, which suggest that it is not inferior. However, we await the results of randomized trials. The future is exciting. What are we planning? We are doing currently a trial of using PIPAC as neoadjuvant for high-risk gastric cancers, where we suspect that peritoneal involvement or omental involvement is possible. So by using PIPAC, we're trying to minimize the chance of doing an omentectomy. There are further developments afoot, including intraoperative imaging procedures using various technologies of fluorescence and hyperspectral camera systems and multispectral imaging, which is still, again, in infantile phases. I think the topic to be covered is vast, but I'd like to say in conclusion that over the last 20 years that I've been undergoing training in oncosurgery and practicing as a surgeon, there's always been a bit of a rift between what's the extent of lymphadenectomy to be performed in gastric cancers. And I think finally we are, both in the West and Asia, unified in the approach that a gastric cancer above the stage of T2 to T4 requires at least a D1 plus, if not a D2 D2 lymphadenectomy. The type of surgery has been fairly standardized with a subtotal or a total gastrectomy. The use of proximal gastrectomy is not very popular in the West. It would be okay to say, I suppose, that we can do away with an omentectomy on a case-by-case basis at this stage. Further advances in minimal invasive and robotic surgery are awaited, and these changes with intraoperative imaging are on the horizon. So thank you very much for patiently listening to my talk.
Dr. Harsh Kanare for valuable talk, sir. I'll just invite my another chairperson, Dr. Shirish Alurkar, Senior Consultant Medical Oncologist, Apollo CBCC Cancer Care, Ahmedabad, to invite next speaker. Over to you, sir. Dr. Shirish. Dr. Shirish is not available, I believe. I'll just request Dr. Inyan Samarsam. Please invite my next speaker.
Yeah. Thank you, and thanks firstly to Dr. Harsh. That was an excellent talk. So for want of time, I think we're going to go ahead with the next talk. So may I even invite Dr. Bhuvan Chugh. Dr. Bhuvan is the consultant of medical oncology and hematology at the Max Healthcare Center in Delhi. He's going to be talking on neoadjuvant and adjuvant approaches in the management of gastric cancer. So Dr. Bhuvan Chugh, please.
Thank you, sir. And thank you, Dr. Tejendra and Dr. Advika, for giving me this opportunity. So I'll just start with sharing my screen. Starting with the topic which was assigned to me was neoadjuvant and adjuvant approaches in the management of gastric cancer. And I would like to give credit for this slide set to Dr. Matthew, who's a medical oncologist at National Cancer Center, Singapore. And he had presented these slides for the November 2020 ESMO preceptorship. And I found these slides to be the most comprehensive when it came to the adjuvant and neoadjuvant topic for gastric cancer. Moving forward, as we understand that gastric cancer, we all understand the surgery is a backbone for gastric cancer. But then with surgery alone, the prognosis is dismal. And even for a stage 1B or for a stage 2, the 5-year survival is around 50%. So we clearly understand that the surgery itself is not enough and we need to add something to it. So there are 3 main approaches as we understand. There is a perioperative chemotherapy, which is given, chemotherapy given before and after the surgery. And then there's the surgery first approach, which is followed by adjuvant chemoradiotherapy, or surgery first approach followed by chemotherapy. And the general practice varies a lot by geographical region, but I think we are all moving towards one unified approach. So coming to the first study which was presented to us was the McDonald's regimen, that is INT 0116 study, in which the patients which were T1 to T4 and with the node, irrespective of the node, and both the gastric cancer and the GJ junction were taken. The patient was randomized to observation vis-a-vis 5FU RT and completion 5FU. That is the McDonald's regimen. And it had shown a positive impact in terms that there was an improvement in the 3-year-old survival by 30, almost 10% approval. 10% improvement was was observed in that. So moving forward, what was seen as as we all say that the devil lies in the details. What was seen in the majority of the patient had undergone a suboptimal lymphadenectomy. And the advantage of chemotherapy or the advantage of chemoradiotherapy was most visible in the patients who had undergone D0 or D1 dissection, which, as we all understand, is not the standard of care in today's world. If you look at the D2 patients who had undergone a D2 resection, the majority of the patients, or rather, there was no significant benefit seen in those patients. And if you look at the patients, so if you look at the forest plots, the patients of D2 subgroup and a diffuse and the patient with the diffuse intestinal histology, there was not much benefit seen. So moving forward, if you look at when you look at the details of the data, the surgery first. In the patient who had undergone surgery, the patient who had undergone the adjuvant therapy, the prevention was majority of prevention was seen in the local regional recurrences rather than the distant recurrences. And with the data available, the distant recurrences was same. So the benefit provided was majority in the local regional arm. And this was obviously, there was a lot of criticism in terms to the toxicity which was present. The patient did have a lot of the neutropenias were there, and there was a lot of GI adverse effect. So coming to the next approach was the adjuvant chemotherapy, in which the patients they undertake surgery first, which is followed by adjuvant chemotherapy. And a meta-analysis of almost 4,000 patients, which included 17 trials, had shown that there was an overall survival benefit of around 6% with the addition of adjuvant chemotherapy. Now, if you look at the development of adjuvant chemotherapy in the gastric cancer, the way it has happened over the past 2 decades is it started with the INT-0116, which was published in NEJM 2001. And then there has been the adjuvant S1 Japanese study. And then there was the Korean classic trial, which had shown the Capox or Zilox. And then now there is this JACRO 07 study, which has given docetaxel plus S1. So coming to the ACTS GC study, which introduced S1 into the adjuvant setting of gastric cancer, patient who were gastric cancer stage 2 or to 3 were undergone a D2 gastrectomy. They were randomized to surgery only, followed by observation, or surgery followed by S1 for 1 year. And it had a positive outcome that the adjuvant chemotherapy had shown almost a 10-year overall survival benefit at the end of 10% overall survival benefit over the period of 5 years, and a majority of the benefit was seen in the stage 2. Coming to the Korean study, which we all are well aware of, that's the classic study in which patient of the similar subset, which patient was stage 2 or stage 3 with gastric cancer who had undergone a D2 gastrectomy. They were randomized to 8 cycles of Capox versus observation, and the study. As we all understand, the D2 gastrectomy has been a standard in the Asian countries now. So in a similar lines, there was a 5-year overall survival difference of around 10% was observed with the addition of Capox. So between the two, in one study we are using a single agent, other study we are using a double agent. So that's where the confusion again. The first confusion began was, is one agent enough, or do we need to use the 2 agents? So if you look at the inclusion criteria, the stage was same. The surgical inclusion criteria was same. The overall benefit hazard was same. However, the duration was 1 year for S1 and 6 months for Capox. What needs to be observed is in S1, the majority of the benefit was seen in the stage 2. However, the Capox, the benefit was higher in the node-positive disease. Well, there's a reverse to it also. S1 has much less toxicity. The grade 3 for adverse effects were less than 5%. As compared to 56% in the Capox. Then there was obviously the oxalic-induced neuropathy. So what came out of both of these studies were a patient who is elderly, who has a stage 2 disease, a single S1 would suffice. In a patient who is young, who has a node-positive disease, a Capox may be a preferred agent. So is there a head-on trial between the single and double? Yes, there is a head-on trial, the JACRO GC07 study, in which the S1 was compared with S1 plus Dosi. And similarly, in the ARTIST-2 trial, it had 3 arms, but among the 3 arms, the 2 arms were a single agent S1 compared with the S1 plus oxaliplatin. What was again observed was that the patient who had received who had received 2 agents, they had a better hazard as compared to a single agent. Now, coming to the third part of it, there's the evolution of neoadjuvant or perioperative therapy. Again, it started, the most famous of it all is the MAGIC trial, which started, which was the British trial. And then we went on to the French Accord trial. And then now we have the German FLOT 4 trial. And we'll be talking about these in a bit of detail. So it all started with the perioperative chemotherapy, or for gastric cancer, it started with the MAGIC trial, in which the 3 cycles of ECF were given pre-surgery and 3 cycles were given post-surgery, and was directly compared to the surgery alone followed by observation. And again, at the end of 3 years, the overall survival benefit was, or rather 5 years, the overall survival benefit was 13% higher in the patient who had perioperative chemotherapy. Similarly, in the French Accord trial, a similar benefit was seen of around 14% at the end of 5 years, with the inclusion of the cisplatin 5-FU before and after surgery. So these 2 trials, they did establish the fact that the perioperative chemotherapy was doing much better in terms of overall survival when it came to surgery alone. Now then came the German trial, in which the MAGIC regimen, that is the ECF pre and post-op, was compared with the FLOT, which was pre and post-op. And we are well aware of the FLOT 4 trial. Most of us have gone through it a number of times. So when you compare the FLOT with the ECX or ECF, again, if you look at the overall survival benefit, at the end of 3 years, the overall survival benefit of around was 10%. And at the end of 5 years, the overall survival benefit was maintained at the end of 5 years. And it was again a more than 10% increase in the overall survival. So what FLOT showed was there is improvement in the PFS and overall survival. There is increased pathological downstaging, and there's an increase in R0 resection. Now, obviously, the toxicity profiles of both of these regimens differ. And now we have used FLOT so much, I think that's, for a person who's coming to us, who's fit, who's young and fit, we all end up using FLOT. We understand the toxicity profile of FLOT. It's not an easy regimen to handle, but then it's manageable, is what I would say. There are diarrheas, there are neutropenias, there are infections and neuropathy. And so the GCSF was not routinely used in the trial, but in Indian setting, I think all of us end up using GCSF without any doubt in it. What is need to be seen is that the majority of the patients were less than 70. Only 1 for the patient was more than 70. And we all understand the majority of the patient of gastric cancer, they come in the age group of 65, 70. And that's where using FLOT becomes a bit challenging in terms of the data which has been given to us. So as far as the perioperative approach is concerned, there are two major subsets. One is the FLOT, which we are able to use for patients who are fit, who are less than 70, who are performance, or rather even somebody who's 70 but who has a good performance status. And we end up using a doublet for a patient who's a bit unfit for a FLOT-based regimen. The doublet usually is a 5-FU with oxaliplatin is favored over 5-FU with cisplatin. But I think both of these regimens are equally good. And I think the French Accord trial shows a good, there's a good evidence for using a doublet as well. Now coming to, the things are not as simple as they appear to be. What needs to be seen is when a patient walks into your clinic and he has a typical T2, he has a typical gastric cancer in which you are unable to identify, you're unable to pick up a node in a EUS. What remains, what comes as a surprise is even after a EUS, we are not 100% sure as clinicians that nothing will come out on the surgery. So the answer remains a bit challenging. So whether to use an adjuvant setting or whether to use a perioperative setting. And what makes it even more difficult is that the hazards are almost same for the entire thing. The hazard in the range of 0.6 to 0.7 in all the 4 in the post-op as well as the pre-op or the peri-op regimen. Just a caveat that the FLOT 4, the hazard of 0.77 is is comparison with MAGIC. It's not a baseline comparison surgery only. So when you look at the curves which are being given for classic and which were presented in FLOT, there is also a remarkable difference if you look at the observation only. So in a in a classic trial, the observation arm only had a good 69% 5-year survival as compared to 36% in the FLOT. I think the problem or the difference is because classic had mostly distal gastric cancers, and all of them had undergone a D2 gastrectomy by Asian surgeon, and all of them had all of the patients who were included were only patients who had had a R0 resection. However, when you look at the FLOT group of patients, there were patients who were gastric cancer and GEJ. There were 84% patient had R0, but there were many R1 and R2s also. However, both of these regimens is where the world is divided between the peri-op and the post-op. So just to provide a bit more clarity, what are the advantages of pre-operative therapy is that there is a good amount of tumor downsstaging, and there is increased resection, there is increased chance of R0 resection, and we get to test the tumor biology. And not all patients, as we all know, not all patients are fit for adjuvant chemotherapy. And why do we say that is because almost 90% of the patients who had completed pre-op chemo, almost 30%, there's almost a drop rate of 30 to 40% in the subsequent post-op chemotherapy. So what are the disadvantages to it is there is a tumor progression, and then there's a 3 to 6% chance that the patient may not be able to progress to surgery. And once, there is always a risk of overtreatment. Somebody who has had a T1, T2 disease and which you're unable to quantify definitely on the clinical workup, you may tend to overtreat in such a patient. Now, there are trials which have compared the post-op versus peri-op treatment ways. The one was the Prodigy study, in which the D2 resection was followed by S1, and the other arm was DOS into 3 cycles of docetaxel oxaliplatin S1, followed by surgery, followed by S1. So what it shown was that there was an improvement in the 3-year PFS when you compare to the peri-op arm versus the post-op arm. But then you never knew that that improvement, is it because of the inclusion of more drugs, or is it because of the way the treatment has been given? And what confused it more was the JACRO GC7 study, in which the S1 plus DOSI had an improved recurrence-free survival as compared to single S1, with a delta of around 16%. Another Resolve study was there, which has what needs to be seen is in this patients who were the part of the Prodigy study, the patients were only T2 node positive or T4. In the Resolve study, the patients were T4 node positive. T4A node positive or T4B node, they could be T4A node positive or T4B. And the patient underwent D2 surgery followed by Capox 8 cycles, D2 surgery followed by SOX 8 cycles, or SOX into 3, followed by D2 surgery followed by SOX regimen. What was seen was, yes, a peri-op regimen had shown improvement in the 3-year progression-free survival of a delta of 8%, and the OS data is immature. However, for the post-op setting, both SOX, both SOX and Capox have there's non-inferiority. Both did equally well. So again, we'll come back to it a bit later. But the two approaches of it being giving it as a peri-op or a post-op, I think this decision is still to be made. But what is clear is from the critics and the ARTIST-2 trial is that the patient who have a limited disease, organ-limited disease, the concurrent CT-RT in the post-op phase doesn't add to the progression-free survival as well as to the overall survival. And that was seen in the critics trial also, which had shown the magic type of regimen, in which the patient given 3 cycles of ECX followed by surgery followed by ECX, and again the ECX surgery followed by CRT, and there was no improvement in the evidence progression-free survival as well as overall survival. And similar story was seen in the ARTIST-2 trial, in which the chemo-RT didn't add anything to it. Now coming to the aggressive histologies, what is seen is the Prodigy 9 trial is there, in which the patient who had signet ring cell cancers, the perioperative chemotherapy had shown benefit over the post-operative therapy, and there was a 2-year overall survival improvement of around 7-8% with the perioperative regimen in the patient who had signet ring cell. However, in the patient who had the patient in the lentis plastica, and in the Japanese arm, the perioperative regimen did not show much of evidence or much of benefit as compared to post-op regimen. However, for the FLOT, I think the FLOT data is still the subgroup in the FLOT, the patient who had signet ring cell type cancer, a perioperative FLOT showed a certain benefit. Now coming to the MSI high patients, I think this is the new subset which has come in, and once we have started checking for immunotherapy now. So patients who were MSI high, or patient who had deficient MSS, it was certainly seen that the patient who in the magic arm, it was seen that the chemotherapy didn't work as well as it worked in the stable patients, but the patient in the deficient MMR, they didn't have as good response to the chemotherapy. And similar story was seen in the classic arm. But the caveat is that there is only small number of patients. There were only 19 patients in the MAGIC and 39 in the classic. And the data of a FLOT is still not examined. So, but what is the trend is absolutely clear is that a patient who has a MSI high tumor, considering a surgery first approach is not a bad option at all. And a combination of immunotherapy along with the perioperative chemotherapy should also be considered in such a patient, and the trials are ongoing for that. Coming to the biomarker-driven, treatment selection, the PRARCA study is there in which the trastuzumab and pertuzumab have been added along with the FLOTs in the perioperative therapy. What I've heard is the recrural is, stopped because the similar regimen in the metastatic, the similar inclusion of the anti-HER2 therapy in the metastatic setting has not resulted in a positive study, and I think the recrural for this trial is stopped. But it did show that there was increase in the PCR rates with inclusion of the anti-HER2 therapy. So to summarize, we have the options of giving pre-op chemotherapy, and we have perioperative chemotherapy versus a post-operative chemotherapy. The patients who have a bulky tumor, who have a large tumor and the margins may not be clear, a chemo first approach works better. There are chances that you may downstage the tumor and have a better R0 and a better survival. And patients who have a aggressive biology such as Lentis plastica or Signet, again a chemo first approach does work. Post-op approach only works if you're certain that we are able to do a D2 gastrectomy, and patient who have had a refractory tumor bleeding or tumor obstruction or MSI high tumor, the surgery first approach should be thought of. These are the few studies which are ongoing at present. There is a preoperative CRT being considered. There is a post-op, peri-op, and post-op. So these are the new studies which are being there. And as the results come in, we'll have more exciting data to us. So that will be all from my side. Thank you.
Thank you, Dr. Bhuvan, for that exhaustive talk. I think we'll keep the questions to the end if there is time. And may I invite the next speaker, Dr. Priya Tiwari. Dr. Priya is a senior consultant medical oncologist at the Artemis Hospital, New Delhi. And she's going to be talking about optimizing chemotherapy and molecularly targeted therapy in gastric cancer. So Dr. Priya, please.
Thank you. Good evening, everybody. We'll be discussing the role of chemotherapy, targeted therapy, and I'll also include slides on immunotherapy in metastatic gastric cancer. So as for many other cancers, the treatment paradigm is evolving around the molecular features of the gastric adenocarcinoma. And there are 4 major subtypes, as you can see from this slide: EBV subtype, MSI, GS, and CIN. Up to 22% of patients might have MSI subtype. This is very important and has a special bearing on the treatment of consideration for immunotherapy. So the current treatment involves not only usage of chemotherapy, but there are many other treatment options which have now come. So especially anti-angiogenic agents like ramucirumab, and we have now targeted therapies, HER2 blocking agents, anti-RK inhibitors, and yes, immunotherapy. So what is important is that the chemotherapy remains one of the important treatment options in first line, second line, and maybe beyond if the patient performance status persists. But yes, across all the trials, somehow it has been seen that there are differences in the outcomes in the Asians versus Western patients. And also the kind of regimen that you may choose, a single, doublet, triplet, it might help to improve the response rates, but at the end, the survival might not be different in the triplets versus doublets, and so on and so forth. A sequential and judicious use of agents is very important. Immunotherapy has now come up, but the trials have shown some conflicting data, and we need to have much more clarity on how to use these agents. So this is how the chemotherapy paradigm has evolved. 5-FU-based chemotherapies, platinums, taxanes, irinotecan, and also anthracyclines, especially epirubicin, form mainstay of chemotherapy treatment options. And slowly and step by step, we are finding that yes, it is possible to improve the chemotherapy based outcomes also by using them very judiciously. So what we have learned from first-line chemotherapy data is that chemotherapy prolongs survival and improves symptomatic control. It offers best of the palliation. 5-FU-based combinations are better than single-agent 5-FU. So what are the 5-FU-based options? Either you use it with cisplatin, you use it with oxaliplatin. You can combine it with docetaxel, but the triplet modestly improves efficacy at the expense of toxicity. So you might like to reserve this regimen for young patients. So median survival for advanced gastric cancer patients have increased to 11 to 17 months because we are able to use active agents beyond first line of chemotherapy as well. So these drugs are interchangeable, especially oxaliplatin is as effective as cisplatin with favorable safety profile. Capecitabine, being an oral drug, much more useful in the present time of COVID. And irinotecan is very effective as cisplatin. What is important is irinotecan is that it does not have any long-term cumulative side effect. Now, especially about the role of anthracyclines. So the initial trial did show the ECF regimen to be a very good regimen. However, we now know that current treatment options, especially 5-FU, FOLFIRI-based treatment options have better time to treatment failures and tolerability than epirubicin-based combination regimen. So what is happening is that though they have demonstrated their efficacy in the neoadjuvant and the adjuvant setting, in the metastatic setting, the anthracyclines are slowly falling out of usage. Now, what about frail and elderly patients? A lot of patients will have compromised performance status. They will be quite symptomatic, especially weight loss. Nutritional status will be quite deficient. So this was a very interesting trial. So you can see the oxaliplatin and capecitabine based regimen here. This trial randomized these patients 1:1:1 into the 3 groups. The first group received 100% of chemotherapy, that is oxaliplatin and the capecitabine up from day 1 to day 21. In the group B, in the level B, it was 80% of the dosage. In the level C, 60% of the dosage. So in the OPD, we tend to think, sometimes we think that the patient does not have good performance status. Maybe we should cut down on the doses. So how much dose can you actually reduce? How much are you comfortable with? Sometimes we wonder, can I reduce the dose? Maybe that will compromise efficacy. So this trial gives you answer there. And what you can see, the nearly overlapping curves tell you that yes, it is possible and feasible to reduce the dosing. And yes, you can very well modify the chemotherapy regimen. So what about second line regimens? So as far as the performance status permits and the toxicity profile, single agent treatment options, chemotherapy options are the way to go forward. You might end up adding a targeted or an immunotherapy drug to the combination. But yes, the choice of treatment will depend upon what the patient has received previously. So docetaxel, irinotecan, as well as combination of docetaxel and irinotecan has shown their data for the second line. And we know that, yes, these agents are very feasible and valid options for second line setting. So if you compare paclitaxel and irinotecan is not better than paclitaxel. And if the patient has not previously taken taxane remains one of the very feasible options. Now, when you compare taxanes, weekly nab-paclitaxel versus paclitaxel, what it was seen that weekly nab-pacli is non-inferior to weekly paclitaxel with higher neutropenia, febrile neutropenia, and peripheral neuropathy. So the side effect profile is very important while choosing these agents. Now, when you talk about targeted agents, there are 2 kinds of targeted agents be active in stomach cancer. One is the VEGF group of drug and the second is the HER2 group. They have now become part of the standard treatment. The other are now showing evolving roles such as FGFR inhibitors and also anti-RK mutations. If you document, then the use of larotrectinib and those kind of agents. So the REGARD was the study which was done in the patients who had prior received platinum or fluoropyrimidines. And this randomized patient 2:1 in the ramucirumab versus the placebo group. And it did show that ramucirumab works very well with 5.2 months of survival compared to 3.8 months in the placebo group. Again, then ramucirumab was tried with paclitaxel and it again showed that this combination works beautifully. The primary endpoint in this trial was overall survival, which was achieved. It was 9.6 months in the combination group versus 7.4 months. in the chemotherapy arm. So what is important is that this combination, because they don't have they overlap, they do not have any overlapping toxicity, the taxanes and the ramucirumab. One is chemotherapy, other is non-chemotherapy. So this combination, if the patient can afford, is one of the very reasonable options. Now, when you talk about HER2 expression, in the stomach cancers, the extent of HER2 expression is less compared to the gastroesophageal junction cancers. But yes, we now know, and after the study of the TOGA trial especially, that in a subset of stomach cancer patients with HER2 expression, the Herceptin-based and the other HER2-based treatment is a very valid option. The kind of this classification or the positivity is very important. So it by ISC or by FISH, as we see in the breast cancer also. So if it is ISC based 3+, that is a strong, complete basolateral or lateral membranous reactivity in 10% of the more of the cancer cells is taken as positivity. And in the equivocal cases, you can go ahead with the FISH, and where you have a HER2 CEP17 ratio of more than equal to 2. Now, what is important is that somehow those who treat breast cancer also, and they agree, they'll be agreeing with me, that the kind of trastuzumab responses you have in breast cancer, it is not like that in the stomach cancer. The reason is not exactly known. It might be because HER2 is expressed much more in a heterogeneous way in the stomach cancer. But this was a very good trial who tried to see that what was the best concordance to correlate with the response rates, a variance study, and what they found that a minimum of 40%. So in the cutoff, we usually take 10%, but what they found, a minimum of 40% of HER2 positive tumor cells and a HER2 amplification ratio of more than or equal to 3. So though the FISH says positivity more than 2, the best correlates with the treatment response come if the ratio is more than 3. So it's not just that you have to document a FISH positivity, you need to see that how positive it is. The stronger the ratio and more is the number of cells expressing HER2, more will be the response to the trastuzumab. So the TOGA trial was the landmark trial. It demonstrated clinical benefit in first line in the high expressors, that is ISC 3+, and FISH positive tumors. So you can see here by the separation of curves in the combination group with it was 16 months and it was only 11.8 months in the non-trastuzumab arm if you are comparing the median overall survival figures. So, and that is why we in the first line setting itself, we tend to measure HER2, and if it is positive, we add trastuzumab. So what about trastuzumab beyond progression? We know in breast cancer, trastuzumab beyond progression works, but this is not the same for this stomach cancer. And the response comes from the T-ACT study. When the paclitaxel and then the paclitaxel plus trastuzumab was compared beyond progression, there was no benefit of trastuzumab beyond progression. This might be because of loss of HER2 expression might contribute to lack of response, and that is why if the disease is progressing, one should always reconfirm HER2 status. What about other HER2 targeting agents? Lapatinib does not work well. Maybe a combination of pertuzumab in combination with trastuzumab offers marginal benefit, but a real promising agent is trastuzumab deruxtecan. So this was one of the trial of phase 2 Destiny Gastric 01 trial. What they did was, in the patient subgroup who had progressed on and after more than 2 regimens, they did a 2:1 randomization with the chemotherapy arm with physician choice of chemotherapy versus trastuzumab deruxtecan. Deruxtecan in the breast cancer is also a very promising drug. However, the primary endpoint in this trial was overall response rate, which according to me is a weak primary endpoint, and there were a number of secondary endpoints. So yes, the primary endpoint did favor the trastuzumab deruxtecan arm, and you can see the overall response rate of 51.3% compared to 14.3%, and so on. All the CR, PR rates were favorable in this newer agent. And median confirmed duration of response was 11.3 months, which I think is very, very exceptional. And if you see the overall survival, and you find that yes, it again favors this new agent compared to the physician choice of treatment. Now, when you talk about side effect, there are 2 major problems with this drug. One is the neutropenia and the other cytopenia, and the second is drug-related interstitial lung disease, which in actual clinical practice could be a nuisance. So what about immunotherapies? A lot of immunotherapy trials across all the cancers, and the gastric cancers are no exceptions. And the initial trials came in the third line setting, then second line setting, and now we have trials in the data also in the first line setting. And the slide documents all the major trials for these kind of cancer patients. So initially, when it was being tried, both the pembrolizumab and nivolumab were tried in the third line and the beyond. And what we see that the pembrolizumab did demonstrate response rates, especially in the PD-L1 positive patients. Nivolumab also showed responses, and the nivolumab responses were actually irrespective of this PD-L1 expression, and we don't exactly know that how to measure PD-L1, it is CPS or TPS, though the balance tilts in the favor of CPS score. Still, we need to have a much more uniform and standardized methods and and validated method for the PD-L1 scoring, and we still for sure does not know the predictive significance in the stomach cancers. So yes, both nivolumab and pembrolizumab as one of the valid option in the third line and beyond in the combination of chemotherapy, especially in this group of the patient. So what these trials tell us, there is immune checkpoint inhibitor monotherapy is better than placebo, but not better than chemotherapy, especially what you see the avelumab trial. However, the good part is they are much more tolerable in the patients who are for third line and beyond. The performance status might be very, very borderline. So these are the agents which actually you can use. But yes, the PD-L1 controversy is still there. So there are a lot of other trials in the first line setting. This is the Keynote 062 with the pembrolizumab trial, the Checkmate 649 trial, the Attraction 2, and the Javelin trial induction chemo followed by avelumab versus chemotherapy for the maintenance trial. Now, just to elaborate few of these trials, the Keynote 062 study. Now, this was a very, very complicated study design, I must say. It had 3 arms, pembrolizumab arm, chemotherapy arm, and a combination of pembrolizumab plus chemotherapy arm. So they had a non-inferiority interpretation and they had a superiority interpretation. So and they did end up measuring the PD-L1 scoring by CPS score. They classified patient on the basis of the CPS more than or equal to 1 and CPS more than or equal to 10. So just to give you a brief idea of what were the main conclusion, that the pembrolizumab single agent was non-inferior to chemotherapy with lower response rates. So it was non-inferior, however, the response rates are lower. So if you want a patient who had a few symptoms, then only maybe pembrolizumab you can use. If patients have a lot of symptoms where we want good response rates, maybe this is, as a single agent, is not the best way to go forward. But yes, this pembrolizumab single agent is much better tolerated and it has fewer side effects. And this was CPS more than 1 as well as CPS more than 10, with CPS more than 10 being much, the extent of benefit was much more. The pembro-chemo combination, when compared to chemotherapy, the overall survival superiority was not established. So you get some data of non-inferiority of pembrolizumab, but a combination is, the superiority data is not there and the extent of superiority was not established, irrespective of the CPS expression. But what did the authors found? That all the figures were better, much better in the Asian patients compared to all other ethnicities. This might be because of the tumor characteristics, because of the patient selection, we don't know for sure. Now you talk about Checkmate 649 trial. This is again a very interesting study, a phase 3 study of chemotherapy versus nivolumab plus chemotherapy combination. And yes, what did they study? That the CPS more than or equal to 5, CPS in the overall population. So they divided the results accordingly. So this is how the results came out, and it was actually quite favoring the combination of chemo-immuno arm. So if you see the primary endpoint of overall survival in the PD-L1 CPS score more than or equal to 5, you see that yes, it does favor the combination chemo-immuno arm. And the same applies to the PFS also. So there were 2 co-primary endpoints, both overall survival and the PFS. It favors the combination of chemo-immuno arms. So this was actually true for all randomized population also. It was true for the patients who had CPS more than 1 also. So across all the patient population. But then subsequently, it was seen that when you see that, yes, there is benefit in all the patients, but it was all maybe driven by the patient who had strong expression of CPS more than or equal to 5. So the results in CPS 1 to 4 is still not very clear or established. Okay, and that is why guidelines across world, they actually recommend that if you have to use this combination, maybe you should use it in the CPS more than or equal to 5 and not in the borderline cases. So yes, and that is why, since there is so much confusion still, a lot of guidelines have still not taken up this in a big way. Attraction 4 was again a randomized phase 3 trial. 724 Asian patients with HER2 negative advanced or recurrent gastric or GE junction adenocarcinoma patients were randomly assigned to chemotherapy or chemotherapy plus nivolumab. Again, two co-primary endpoints, PFS and overall survival. And when the data was presented, median PFS was significantly improved with the combination therapy. However, the trend was only slightly better for the overall survival, favoring slightly the combination in chemoimmuno arm. Now, what is important is you see a 17.2 months of overall survival in chemotherapy only arm, which I think is very good for a chemotherapy only regimen. This might be also because 27% of the patient in the control arm received post-study treatment with an anti-PD-1 agent. So, this might be a confounding variable. Now, when you talk about a stratification according to PD-L1 overexpression, neither PD-L1 overexpressors nor PD-L1 negative patient had a survival benefit from the combination immunotherapy and the chemotherapy. But importantly, the trial used TPS scoring and not the CPS scoring to designate PD-L1 overexpression. And we don't know if the TPS is as good as CPS. We don't even know that a CPS is good, but maybe a CPS might be a better scoring compared to TPS for these patients. So what about the guidelines? Where do they place all these agents and how do we go about them? So what the NCCN says is that a combination chemotherapy might be a way to go forward with the oxaliplatin-based regimen preferred due to over cisplatinum due to lower toxicity. You do HER2 in all the patients, and if HER2 is positive, you add trastuzumab in these patients. The thing is, if the HER2 expression is negative, then maybe you just give them chemotherapy. And if there's a strong expression of PD-L1, you might add nivolumab in this group of patients if the affordability allows it to do so. There are other options also, and you can use your chemotherapy options based on the performance status, tolerance of the patient. And one has to look for the neuropathy, etc., which can be both a bothersome problem with both cisplatinum and the oxaliplatin. So what about the other second line and beyond? So as I said, demonstrated the data of ramucirumab plus paclitaxel is one of the standard option. And yes, if the patient continues to have HER2 overexpression, then trastuzumab deruxtecan is also coming as one of the standard option. So you can just use the agents which you have not used previously and based on the previously mentioned data. Pembrolizumab for MSI high patients groups and or if the TMB is high, so the cutoff is usually taken is more than or equal to 10 mutations. So across all the cancers, if you have MSI high, you have TMB high, then you can use pembrolizumab in this group of patients. So this is how the ESMO guidelines are actually using. So if you have an inoperable metastatic gastric cancers and if you have to choose a second line treatment and beyond, so depending upon the performance status, you choose your options. And if there is presence of MSI high, then you can go forward with the immunotherapy only option. And immunotherapy only option can be used irrespective of performance status of the patient. So yes, the first step is you can use the option of chemotherapy. If HER2 positive, then combine these patients, then use the option of trastuzumab combination. The second line and the beyond very well depends upon the performance status and the presence and absence of the various other mutations, such as the extent of PD-L1 expression with the usage of CPS scoring preferred over TPS scoring, and also other mutations such as the TMB and the MSI. So wherever it is possible, a combination treatment, if present, you should always choose a combination which has a non-overlapping toxicity. And paclitaxel ramucirumab remains a very feasible option, provided taxanes have not been used in the first line setting. For the HER2 positive tumors, it is important to document the HER2 positivity even after the progression. Trastuzumab deruxtecan is one of the options, and I think now in India also various such trials are coming up. So to conclude, the doublet platinum and the fluoropyrimidine backbone is recommended for the first line advanced gastric cancer. Triplet chemotherapy with taxanes may be considered in fit patients. However, the side effects always needs to be looked at. Reduced dose doublet improves tolerance and quality of life in frail and elderly patients. We see that we can decrease the dose as low as 60%. So using the options judiciously in a sequential manner extends line of therapy, improves overall survival. The standard second line includes taxanes with ramucirumab or paclitaxel inotecan or ramucirumab alone. And the standard third line includes trifluridine piperacillin. This is much more valid for the Western population because this combination is not easily available in Indian setting. For HER2 positive advanced gastric cancer should receive trastuzumab in the first line, if not taken in first line, in the second line setting. And trastuzumab deruxtecan might be considered in third line, and beyond the data is much more robust in the Asian nations. But yes, the trials are evolving in India as well. So yes, what is happening is that because of the expansion of agents, not just in the better usage of chemotherapy options, we are wiser because we have targeted drugs, and we also have data of immunotherapy where we can use them, especially in the later line of setting, to improve survival markedly, especially in a subset of patients where you have MSI or you have high tumor mutation burden. Thank you. PAPs, but immunotherapy is still very costly, and ramucirumab is again very costly drug. So, you know, there is a term called as efficacy, and there is a term called as cost effectiveness.
Yeah. Well, we hope that, you know, at least in the near future, that's something that we can use. So I think we're coming to the end of the session. We did have a few questions in the chat box, and those were primarily addressed to Dr. Harsh. Is Dr. Harsh still there?
I think he had answered many of the questions in the chat box.
Okay. So
yeah,
hi. Just very briefly, Harsh, can you just summarize your thoughts on omentectomy, because there were quite a few. Just very, very briefly. We are running short of time.
Sure. Look, I think the issue of omentectomy versus no omentectomy is basically arisen because of introduction of minimally invasive cancer surgery, and it's more a question of whether it is necessary rather than whether there is any evidence for or against. And I think in selective cases, you can get away without doing an omentectomy. I think we still need to have phase 3 randomized trials to see whether there is any added benefit of an omentectomy or whether there is actually an added benefit of not doing an omentectomy. But certainly the meta-analysis of the retrospective studies do suggest that it is definitely feasible to do gastric cancer operation without an omentectomy in selected patients. So yeah, we do it in early stage gastric cancers.
Yeah, thank you. Thank you for clarifying that. And I think it's almost midnight in Adelaide, so I think we'll let you go. So thanks everyone. Thanks for all the speakers for sticking to time, and thanks for the organizers again.
Dr. Inian, I'll just request to announce next speaker, please.
Okay. The next speaker is Dr. Tejendra Singh, and he's going to be talking on the role of ramucirumab in GI cancer. Over to Dr. Tejendra.
Yeah, Sarika, I think I had recorded the meeting. Can you? Today I'll be presenting real-world data on ramucirumab in metastatic gastric cancer, and it this data basically is from both the East and from the Europe, and also we'll discuss briefly about the rainbow data also. So there was one paper which was published in basically in a Korean, it was a Korean data, and it was data from the Korean Cancer Study Group, and which came in 2018. It was a real world data from the East, and they have taken patient from June to December, June 2015 to December 2015. Around more than 260 patients were taken into the study, and there were around 28 sites which were involved. So median follow-up here was around 9.2 months for the combination group, that is using ramucirumab with paclitaxel, and 9.6 months for the monotherapy. And the combination patient had significantly younger patient. You can see here 57 as compared to 62 years. And also HER2 was slightly on the more side, approximately 14%. So this data basically was looking into the efficacy and tolerability of using a monotherapy or in combination with paclitaxel in gastric cancer patient. And it was a study done by the Korean Cancer Study Group. So you can see from here certain things which are important, the efficacy and tolerability based on this combination or monotherapy. You can see the PFS and the OS. When you see the PFS with the combination, it starts separating quite early, even though at around 6 months it has almost mixed over there. So the median PFS for the combination was around 3.8 months, and as compared to ramucirumab, it was only 1.8 months, and it achieved its p-value. When you look at the overall survival, the overall survival was much better, and you can see the curve separating quite early and maintaining it for a long time. And the median overall survival was around 8.6 months for the combination as compared to the monotherapy, which was approximately 6.4 months. And the 6 months PFS rate was also double in the combination as compared to monotherapy. So this is one more chart where they showed us how many patients had a good basically disease control and the overall response rate. The disease control rate was quite high in the combination arm. You can see here nearly 66% had a disease control rate, with approximately 37 in the monotherapy. And complete response, partial response, stable disease was much better in the combination as compared to the monotherapy. And even though numbers are more high in the combination, but the overall complete response, partial response was slightly on the higher side. There was one more data which came from the European group. It's from the Ramos study, and here they are used in the second line in the metastatic gastric cancer. And this study involved patients which they had taken up from October 2014 to Feb 2016. Nearly 167 patients in the ramucirumab, and 25 Italian hospitals were involved, and they had used a compassionate use program in this subgroup. Median follow-up around 11 months, and median age group was in the range of around 61 years. Here also, as compared to the data which we provided from the East, HER2 status was slightly on the higher side, around 27%. Nearly there were large group which had taken combination. Nearly 90% had taken ramucirumab with paclitaxel, and approximately 10% had taken monotherapy. So these are the results from the this study group. Basically, it's a real-world data from the Ramos study. You can see around 167 patients. Median age was around 61. Predominantly male population, predominantly gastric and esophageal junction one, and nearly 55% had unresected disease. Bulk of the patient had a ECOG of 0 to 1, and treatment, like I said, nearly 90% had combination as compared to 10 only which had monotherapy. So these are the data looking at the PFS and looking at the basically the overall survival. You can see here the ramucirumab with the combination as compared to the red line, which is monotherapy, the median PFS was around 4.5 months as compared to 2.7 for the monotherapy. The OS data also similar to the East group. Basically, OS data was also on the higher side. It was 8.3 as compared to 4.8 months over there. You can see here that there were some patients who achieved CR, even though the percentage is quite less, 1.3%. But the disease control rate was around 60%, and the partial response up to a tune of around 19% over there. A good response in a second line setting when you are using a combination. So this is just to give you a brief summary about real world data from the East and West, and also the Rainbow study, which is a standard landmark study for the ramucirumab coming in place for the CS stomach. So you can see here the median PFS in the clinical trial, the randomized control group, and the real world data. It's basically almost in the range of around 4.2 to 4.5 months. And median overall survival is in the range of around 8.2, 8.3 to 9.6 months in the Rainbow study. And the overall response rate is in the tune of more than 20% in almost all the group population. So what are the key takeaways from the real world data? From the randomized control trial, we learned that the Caremza is a first biological agent to achieve a statistically significant survival advantage in the second line treatment of gastric adenocarcinoma and upper GI, basically in combination with paclitaxel and also as monotherapy. And this drug has a very good safety profile and tolerability that makes it possible to treat cancer while maintaining the quality of life of the patient. When we see the real world data, we also learned that treatment patterns and ramucirumab's effectiveness from the real world studies are consistent with those from the randomized clinical trial. Remember, there are two big trials which have laid the foundation for this, Rainbow and the REGARD study. And the real life practice allows us to consider this combination as a new standard of care in the second line setting. So there was a special article which was published in Annals of Oncology in 2019, which looked at the basically it was a Japanese medical oncology group and ESMO initiative endorsed by a lot of other groups, and they also gave a guideline for a pan-Asian subgroup for the management of patient with a metastatic gastric cancer. So in any patient, whoever is inoperable or metastatic, we have two options: best supportive care and palliative care. We normally go for best supportive care only for patients who are unfit for treatment. And based on the HER2 positive status, whether they are positive or negative, and apart from that, whether they are eligible for the clinical trial, we consider for it. So those patients who are HER2 negative, normally the standard line of treatment is 5-FU plus platinum based, either doublet or triplet based on the patient's condition. And if they are positive, we have to add trastuzumab to it. And if suppose they fail on trastuzumab or they fail on this platinum 5-FU based chemotherapy, doublet or triplet, we normally go for second line chemotherapy at progression. And after, in a second line setting, based on the performance status, we decide what should be done. So basically, nowadays we have a lot of new things coming up over there. But in a second line setting with a very good performance status, we have either a combination of ramucirumab and paclitaxel, or patients who are having a MSI high, they can be offered PD-L1 inhibitors like pembrolizumab and nivolumab. And those who are having performance status 2, a similar thing what happens with the PS1 and 2. So only the patient who are PS4, the best thing is to go for best supportive care. So here the things have changed a lot, because now we have a combination which gives a better result than only monotherapy. So this is a Rainbow study design which looked at as an inclusion criteria of metastatic non-resectable locally advanced GE or gastric adenocarcinoma, where the disease progression has happened less than 4 months after the first line of last dose of the first line therapy. First line therapy containing any platinum or 5-FU doublet with or without an anthracycline and with a good performance status. And they were stratified based on the time to progression of the first line therapy, geographical region, and disease measurability, whether the patient disease was measurable or not. So nearly 665 patients were enrolled and randomized, and they were randomized into two categories where the combination was given or basically patient was given only chemotherapy with paclitaxel. So here the paclitaxel was given in a weekly fashion, 80 milligram per meter square, and ramucirumab at 8 milligram per kg, which is the standard dose on day 1 and day 15. And they were given until disease progression or unacceptable toxicity. And the CT scans were done every 6 weeks. We're looking at the survival and the safety. So this basically is a phase 3 study with the primary endpoint is overall survival, and the secondary endpoint is PFS, time to progression, objective response rate, and safety assessment and quality of life. So they looked at PFS, TTP, and objective response rate and safety assessment. So you can see the combination of approximately 322 patients. Here also it was around 329 patients. Basically the grade 3, grade 4 side effect was slightly more in the combination where the like hypertension was slightly on the more side, a slight amount of chances of injury, but overall the safety profile of the drug is very good. So this trial basically met its primary endpoint, and the combination of ramucirumab and paclitaxel, it confirmed a statistically significant and clinically meaningful overall survival benefit of more than 2 months. It is a median overall survival of more than 2 months. Risk reduction of disease progression or death by approximately 37%. So there was a significant benefit in the progression-free survival and overall response rate, which was observed in this study. And when you add ramucirumab to paclitaxel, it did not impair the quality of life as I had shown in the previous chart. So this combination is a good thing to basically in the second line setting, and the objective response rate and the PFS does improve with this combination. Thank you for your patient listening. Thank you.
Thank you, Dr. Tejinder Singh. I announce for my next chairperson, Dr. Sudesh Vanse, Senior Consultant Surgical Oncology, Nanavati Super Specialty Hospital and SL Raheja Fortis Hospital, Mumbai, and another chairperson, Dr. Atul Sharma, Professor of Medical Oncology, All India Institute of Medical Sciences, Delhi. Over to you, sir.
Hello. Hello. Hello.
Yes, sir.
Can you hear me?
Yes, sir.
Okay. So I'm Dr. Fanche, and I welcome all of you for this interesting session on esophageal cancer. We have my co-chairperson, Dr. Sharma. Are you there? Hello.
Very much there.
Hello.
Yeah, I can see you. I can.
Yeah, nice to meet you, sir. And I think the moderator of the session, we have an eminent personality, Professor and Head of Surgical Oncology from Cancer Institute, RDR, Dr. Arvind Krishnamurthy. And we have an eminent panel of panelists. I see a lot of them are my friends and colleagues, and it's nice to see all of you in these difficult and trying times, especially without the mask. Okay. So I think Dr. Sharma, if you want to make some comments, and then Dr. Krishnamurthy can take over.
No, we can straight away start. I believe we are already somewhat late.
Okay, Dr. Krishnamurthy, sir.
Yeah, maybe at the outset, when I'm sharing my screen, I'd like to thank Anil, Advaita, and Tejinder for putting up this wonderful program together. And
Dr. Arvind, will you please?
Haji?
Yeah. Full screen, please, sir.
Yeah, it's happening. Yeah, at full screen. Yeah, great. So I think in the interest of time, we will quickly go. I have an eminent multidisciplinary panel for everybody is there, Sarika? All the panelists are there, just to quickly confirm so that I can direct the questions to them.
Hi, Arvind, I'm there. Gajay here.
Great. Yeah, great. I can see most of you all, but
yes, sir.
Sarika,
So Dr. Shrikant and Dr. Tanveer is not available. So
Dr. Tanveer is here.
Yeah, sir. He will be there, sir. Yes, sir. Dr. Tanveer Majid is there. Dr. Shrikant will be joined soon, sir.
Great. I saw most of them during the course of the talk, and we will just. Yeah, hi everybody. Just a couple of housekeeping slides to just put the talk in, or the panel in perspective. 8 most common malignancies, 6th most common cause of mortality, 2 common histologies, squamous and adenos, and global variation is there. We are seeing more amount of adenocarcinomas in the West, and of course, because we are discussing middle third, obviously the mandate would be squamous cell carcinomas. And this is, I just put this slide for people who are in training, just to get to understand the perspective of clinical terminologies, with what exactly is middle third of the esophagus in terms of anatomy. It could be divided into upper thoracic, that is 18 to 24, and mid thoracic, that is 24 to 32, and that constitutes the middle esophagus. Prashant, you want to comment anything? Is this of any clinical significance, or we will just move on from here?
Yes, I think we can move on from. Very important, because our investigations workup and also management completely depends on the location of the tumor, and so this is at least for, it's very, very important to know, because your extent of surgery, nodal dissection, type of anastomosis, everything would change depending on the location of the tumor.
Great. Yeah, I think it's very important for all of us to know some things about terminology, something the AJCC defines, something that is defined by the clinical. Some people say aortic arch to inferior pulmonary vein, some say azygous to inferior pulmonary vein, but I'm sure that, it may not have that much of a clinical relevance, but nonetheless, it's important while you're reading CT scans. Just to say about the histology, of course, we are discussing squamous cell carcinomas. I just wanted to say, Ashish, and you're coming from a big center, and I've seen a couple of publications that are there from your center. Any prominent histology, squamous versus adeno, very quickly, so that we can move on to the case.
Right, sir, I feel we still see a lot of GE junctions, and therefore adeno remains a much larger number. But we do have patients from Northeast, and especially the alcohol, the caustic injuries, and the tobacco related, the middle and the upper, which are predominantly squamous. So, I mean, I wouldn't know the exact numbers, but I will say maybe 30-70 is my guess, if you're including upper or the lower esophagus.
Anybody else? Dr. Mandal, would you want to comment on this in your practice? How do you see more squamous, more adenos, or how is that, just to throw things in perspective? Or anybody can take it. Dr. Tanveer, how is it in your practice? Yeah. Dr. Mandal, I think I'm not able to hear you.
Yeah. So I fully agree with Dr. Ashish in this. Gradually, we are seeing more of GE junction, but yes, when it comes to upper or middle, we are seeing most of squamous cell carcinomas.
Great. Tanveer, you wanted to make a point before we could sort of move into the.
So I'm getting a lot of adenocarcinomas, but patients which are coming from Bihar, 65 or 37, like that.
Great.
In my family also, I've seen quite a few adenos here because of near related adenos.
Just to share with you all some of the data that we had come out from our center. I'm sure that some other data would be coming from many other centers. What we found was very sparse Indian data. 4% of all cancers were the esophageal cancers, and we had about 80% of them were squamous, and about 10% odd were adenos. Though they were increasing, still squamous constitutes the bulk. The reason why I'm saying this is this topic is increasingly relevant because at least close to 80% of our cancers, and I believe in many other cancer centers also, a similar trend would be there, although we are seeing more amount of adenocarcinomas, as was pointed out by Ashish and Dr. Mandal. So I just come directly to a case, and I thought that we would discuss possibly a locally advanced cancer, because this is about 90% of the cancers that we see would be locally advanced, and I don't see any debate in that. Anybody else would see more of early or something of that sort, or Dr. Gajanan, how is it?
No,
like
I don't think we see too many early stage esophageal cancers. Most of them are locally advanced and will need some new adjuvant therapies before they come on the table.
Great. Wonderful. So we go right to the case. This is a male, 59-year-old, PS1, progressive dysphagia, 3 months, weight loss over a month. And I'm not going to the other details, but because I thought this is pretty much routine. Endoscopy was ordered, a circumferential growth, middle third, partially occluding lumen. Scope was past born. Beyond the biopsy was a squamous cell carcinomas. I just wanted to understand, very importantly, the flow of the patient at your particular services. For example, Naveen, how is it like, would you be the person who is sort of taking the meat of the decision for these particular patient, or how is it that happens in your practice?
Yeah, it's largely how we direct it. I mean, the next point of investigation to stage the disease, but we do usually have concur on the thing over a tumor board every Friday afternoon. So we do sit down to thrash out to see what would be the best plan for the patient. Largely, though, I mean, there has to be one consultant on the driving seat. So it's usually the surgical oncologist who's seen the patient first.
Right. Ashish, how is it in your center? Who do the patients normally get registered under? Because you're coming from a larger center, and then Prashant can quickly chip in as we move on.
I think, sir, if they don't know that they have cancer, they usually go to gastroenterology. And if somebody has already scoped them and they know, they get triaged to either surgeons or the radiation therapist, depending on who is having OPD that day.
Great. Prashant, how is it there at the GIPSA?
Exactly. So those who are at the diagnosed case generally comes to either the treating surgeon most of the times. But undiagnosed cases go diversely because we treat with broader specialties. So ENT also gets a lot of cases of carcinoma esophagus, because dysphagia being one of the problems, and then they are referred accordingly. But once it's diagnosed, they most of the times primarily are generally seen by a surgeon and then taken forward from there.
Great. Okay, yeah. So by and large, I think seen by surgical services. Although I must contend that the treatments are multidisciplinary. Of course, these are pretty much elementary. I don't really want it to go to the cardiopulmonary and nutritional evaluation. I feel these are pretty much important. And I possibly because surgeons would be evaluating it, I would say, how do we sort of image in your particular center, whether we go directly for a PET CT or a CT scan? Dr. Nikhil Dharmakadikari, the surgical oncologist, he's there around. I saw him as well. So, Dr. Nikhil, can you take this in your? How do you sort of stage these patients at your? What is your choice at least?
So once diagnosed with an esophageal cancer, and if it is a bulky lesion on endoscopy, I usually prefer going with a PET scan rather than a CT scan.
Right. PET CT scan. Anybody else who would want to sort of have a differing opinion?
I will do a PET CT, of course, but with that, I would also like to do a HRCT of the chest to see the exact nature of the extent of the lesion.
Great. Okay. Anybody else? So, Gajanan, you do PET CT as well as HRCT?
Yes, HRCT.
So for a very, very, very superficial looking and very small lesions, maybe we would prefer an endoscopic ultrasound as well.
Great. Wonderful points. So just wanted to say that I guess majority of the centers, can I say that they have shifted to having PET CT scans, if of course subject to availability, as a preferred modality of investigation for some of the locally advanced cancers? Would that be a fair statement to make in the interest of a message to everybody?
Of course.
Yes.
Yes.
I agree with you.
And they say that about say 20% of these patients' decisions may get changed by use of a PET CTs, and And this was the PET-CT report for this particular patient. I'll just read it out to you. I have a couple of pictures of the scans. It was a bulky lesion, D6, D5 to D7. They said suspicious adhesion of the aorta with the possible loss of intervening fat plane and some faint right paratracheal node. And some of the images, it was quite difficult to capture in the PET-CT. So some of these images are here. It's pretty large, bulky growth, D5 to D7. And this was the picture. So what next? Like, how do you sort of, this is the PET. So we know this is a young gentleman, middle-aged rather, 59. Excellent performance status, squamous cell carcinoma, middle third, and sort of a bulky lesion with some suspicious sort of involvement. Tanvir, how do you sort of go about? Dr. Nikhil, Kalyani, I'll be coming to you shortly.
Two things, yeah. I mean, first thing, it's a mid-third lesion which is in contact with the tracheobronchial as well as the aorta.
Right.
So first and foremost, I would like to do a bronchoscopy and see for a posterior tracheal wall mobility.
Great.
The other thing is,
go ahead.
Other thing is we can actually do an endoscopic ultrasound, because according to a meta-analysis published in 2008, the evaluation of endoscopic ultrasound for tracheobronchial involvement is great for advanced tumors, that is T4 tumors, and it's also excellent for early stage T1 disease. So I would want to do an endoscopic ultrasound and a bronchoscopy. And endoscopic ultrasound, I would like to, because the lower part is in contact with the aorta, I would like to do an EUS for the aortic involvement and the area of circumferential involvement. So these 3 points is important in trying to treat this patient, which I would do.
Tanvir, you elegantly summed it up. Bronchoscopy, yes, mandatory. Bronchoscopy in this gentleman was normal. You made a very elegant point about using endoscopic ultrasound for the advanced cancers as well. So, Dr. Mandal, you had a comment on endoscopic ultrasound. How is your sort of, normally we are traditionally sort of, have the belief that it has to be done in early stages. Of course, those cases are far and few in our practice. CIST1 are very less. And how is it in your practice? And Dr. Nikhil, you can also want, Kalyani, you can also want to comment on this after that. Dr. Mandal, since you mentioned about endoscopic ultrasound, how is it?
So at our institute, usually we do not advise endoscopic ultrasound for advanced lesions. Very much for very superficial lesions when you know that endoscopic dissection itself is going to be a treatment modality. For advanced tumors like this, I think the consensus is already there. We straight away go ahead with a PET-CT scan, but yes, we prefer double contrast, contrast.
Dr. Nikhil, Kalyani, any thoughts to add?
No. I agree with the Dodul also. We don't do the endoscopic ultrasound for such advanced disease. We just do a PET scan and a bronchoscopy to rule out a tracheal infiltration. And for early stage, yes, endoscopic ultrasound needs to be.
Great. And I think great points. I think Tanvir said substantiated with some evidence, but the classical teaching is to do a US for the early cases, maybe around T1 or T2 as well at times, because some of these lesions, T2 especially well differentiated, there could be some people who may want to take them for surgery. So in those cases, you definitely do. Advanced is possibly to look into this. But in case we also didn't do an endoscopic ultrasound for this particular patient. For us, essentially, prior to that, thoracoscopy, brain imaging, any takers at all?
Not really.
Not really. Great. I just mentioned this so that we just to say that we don't do it. At least they say sometimes brain imaging, especially in adenocarcinomas, they say the incidence of brain mets may be around about 13%, but it's not in clinical practice. Definitely not in squamous cell carcinomas. In our patient, the bronchoscopy was normal. We did not do an endoscopic ultrasound. And how do we sort of proceed? And I think I want each of you all to sort of, Naveen, you can start off how. So this is a bulky middle third lesion. What would your treatment protocol? I want everybody to quickly chip in for this. Naveen, you can start. How do you go about for this gentleman?
If you ask me an honest opinion, I am biased towards a neoadjuvant chemotherapy. My initial experience with combination chemoradiation is neoadjuvant. I had seen some hiccups with patients not complying to the completion of treatment and even defaulting on not completing surgery. So I have seen a reasonably good turnaround with neoadjuvant chemotherapy, and I continue using that. Of recent, I've seen incidentally patients have come post neoadjuvant chemoradiation for surgery and have sailed through quite comfortably. So I'm opening up to a little more fit patients being considered for the protocol. But if I had to vote on it, it would be neoadjuvant chemotherapy.
So neoadjuvant chemotherapy is your take. Dr. Nikhil, the surgeon?
Just in passing mention, I just wanted to, there was a big debate on the previous slide on bronchoscopy and EUS. Arvind, in this case, when we are seeing a PET CT, which is not showing gross infiltration, just a mild loss of fat plane, and we know we are going to, standard protocol now is neoadjuvant therapy. So if you're going to go in for neoadjuvant therapy, are we really achieving much by even doing an invasive bronchoscopy right now? Rather keep it in reserve for a probable non-responder prior to resection, post neoadjuvant.
Great. Okay, we'll come to that, Naveen. But Dr. Naveen, Dr. Nikhil, surgeon. No, very quickly, if you get us a consensus, if I were to say that upfront surgery is a definite no. I think that I've highlighted it because that should be the clear message across that we give to the audience. Amongst these therapies, these three therapies, and we would come to the evidence. If you could very quickly, all of you, tell me what is your practice at your institution, and
I'll go ahead with neoadjuvant chemoradiation.
Gajanan?
Evidence suggests neoadjuvant chemoradiation, but I agree with Naveen that very few patients will tolerate it. So we also go ahead with neoadjuvant chemotherapy usually in these patients. Yeah.
So Prashant?
JIPMO, most of the patients receive neoadjuvant chemoradiotherapy followed by surgery, except for a few of them where the length is a bit more than 10 centimeters. And you have a higher Neville node, those patients we consider for NACT. But otherwise, most of the patients go for NACT.
Tanvir, I would come to you, I think. Because most often they are sort of seen by surgeons and then they are referred also. And Tanvir, what is your take on this?
Neoadjuvant chemoradiation, the patient is fit. And as Prashant said, a long segment with the node upper beyond the field. I would consider neoadjuvant chemotherapy.
Great. Ashish, what would be your philosophy for the bulky tumor?
I would suggest to use the cross regimen. I mean, there were some concerns about toxicity. Some centers may still be using Cisplat 5-FU with radiation. That is pretty toxic. The cross regimen with weekly carbopacly is well tolerated. I mean, you have to simultaneously take care of the nutrition. An NG tube should be in place. Weekly, they should see dietitian. And in our experience, the weekly chemo is okay. I mean, it's well tolerated. And this being squamous, I'm hopeful I may get a complete response. And complete responses are way better in CTRT as compared to only chemotherapy.
Wonderful. Dr. Nikhil Kalyani, your thoughts,
I agree with Dr. Ashish. The neoadjuvant chemo radiation is well tolerated with weekly Pecli carboplatin. So we are not.
You would follow the cross.
Yeah, we are not seeing any significant toxicities.
Dr. Mandal, very quickly, and we can sort of. I just wanted to have a sort of say everybody.
We follow cross protocol with weekly Pecli carbo, and we avoid putting a stent upfront in these patients. We prefer putting either NG tube or other fitting tubes in case it is required. And
so
we prefer surgery. That's our standard.
From what I see, I think definitely, I think all the panelists seem to suggest that no for upfront surgery, yes for some sort of a neoadjuvant therapy, and the majority seem to prefer the cross protocol. And of course, some of the surgeons, couple of them at least, would sort of have a leaning towards neoadjuvant chemotherapy. What about definitive chemotherapy radiation? And I would throw it to the radiation oncologist, Dr. Mandal and Dr. Kalyan. What is your sort of philosophy? When do you sort of offer this?
So it depends on joint discussion with our surgeons. If they feel that after initial chemoradiation surgery may not be an option, then we decide to go ahead with upfront radical CTRT.
Yeah. Dr. Nikhil Kalyani?
Yes, I agree with you. If the surgeon says they're definitely inoperable, then only we go for a definitive CTRT. Otherwise, neoadjuvant followed by surgery will give the best outcomes.
No, I will. I think everybody has voiced their opinions. I pretty much agree with everybody. There is, of course, for adenocarcinomas, I think the panel following us would sort of tell results seemingly superior to chemotherapy and radiation in squamous cell carcinomas, but still there is still a controversy in this. Many RCTs, 3 meta-analysis, network analysis in 2018 says slightly better survival with neoadjuvant chemotherapy and radiation, but slightly higher mortality. And a very, very more recent meta-analysis that actually came in March 2021 in Scientific Reports again said that you can't really choose one over the other. So the problem is that we don't really have a robust comparisons between these two arms, and that's the reason why you have meta-analysis after meta-analysis. Some show superiority of chemo radiation, and some say that chemotherapy should be reasonably good enough. So as long as you give some form of neoadjuvant therapy, chemotherapy or chemo radiation, you should be good enough. I think, would that be a reasonable summation for this strategy?
Yes, that's fully agreeable.
Yeah, agree.
Yeah, I think everybody is sort of, and one must also understand that there is a regional variability. A lot of neoadjuvant chemo RT is preferred in Europe and the US, and neoadjuvant chemotherapy in the Asian countries. So if you have a lot of Japanese and possibly a little bit Chinese also, maybe I should not tell that but at this point of time, but I think their inclination from the Asian countries seems to be towards neoadjuvant chemotherapy. So our patient received neoadjuvant chemotherapy and radiation, and I think Ashish and Dr. Mandal, you all said about cross protocol, so I don't really want into the protocol because there's something little more we have to sort of cover on this. Restaging after induction therapy, and this is something that I thought is very, very important. When do we do it? Gajanan, how is it in your practice? Say you said you prefer neoadjuvant chemotherapy. So when do you sort of restage, and how do you restage very quickly?
I will give him 3 cycles of chemo and then do a PET scan, PET CT, to see the metabolic response, and also HRCT test to actually see the physical extent of the tumor and decide on operability.
Great. I think your PET CTs are not providing you all the information.
No, they are providing. I mean, they are excellent PET CTs, but somehow I am not comfortable looking at the CT scan quality of the PETs. I would rather
ask them to give you more images.
Yeah, I think so.
Tanvir, you had a point to make.
I always tell them to couple up a contrast CT along with a CT. So they give me separate films for that. So that looks okay for me.
Great. So Prashant, say you said neoadjuvant chemo radiation therapy. When do you, when and with what modality do you restage?
So generally after about 4 to 6 weeks post completion of neoadjuvant chemoradiotherapy, and the common modality used is a CE-CT scan and not a PET scan routinely. But however, if no clinical improvement or if there is clinical progression, a PET scan is definitely done. So I agree that PET scan may be the ideal investigation for restaging, but at our center, we do not follow it routinely because of other logistic issues. So CE-CT gives us information, and very rarely that we needed to get a PET scan which changed the management post neoadjuvant chemoradiotherapy.
Great. Any other comments like of PET CT for restaging? I know very few centers do it. We actually do it also. We have some data also. Anybody else would restage with a PET CT? Dr. Mandal, you are wanting to comment on this.
Yeah, so we do it routinely for all of our patients for response assessment, and our preference is somewhere around 6 weeks because our surgeon prefers to operate around 6 to 8 weeks. And we never advise it before 4 weeks.
Okay, great. Any other thoughts? Naveen, you had you wanted to sort of PET CT in your practice, or?
Yeah, we do. If at all we are asking for a reassessment, it is usually with a PET CT. I also base a lot of my decision on the clinical response of the patient.
Right. No, if you see the NCCN guidelines and some of the evolving guidelines, there seems to be a suggestion that PET CT may be slightly better in terms of response assessments. Though I entirely agree with Prashant that a CT scan would be a reasonably good option per se. And there are also other advantages of PET-CT. You can sort of, they say you can do a good response assessment. We've actually seen a couple of patients progress as well. So our PET-CT has actually picked up some of these lesions as well. So we are trying to mine the data. We may sort of, share it with you at an appropriate point of time. Of course, it is predictive and has some prognostic abilities as well. And now coming to this particular patient, I think the PET-CT showed a complete radiological response. As Ashish was telling, squamous cell carcinomas, neoadjuvant chemotherapy, they sort of respond well. Endoscopy is also bang normal. What next? Ashish, since you said this, I would sort of come to you with this a complete clinical radiological response in this particular gentleman. How would sort of your
I think from whatever my understanding is, even though I have not read up recently on but any randomized or prospective trials, I think if the patient can be watched and the patient is motivated, which I will say 50% of our patients don't fulfill this criteria. They are either from far off, or they may never come back to you, or they don't have the funds to keep doing CT endoscopy. But because we have seen from retrospective series is that these complete responders have very good survival, and even when they relapse, we can salvage them. So observation is an option, but I mean, I don't make that decision.
Sure. Great. Dr. Nikhil Kalyani, I want the radiation oncologist to sort of chip in here. Dr. Nikhil and Dr. Mandal can sort of complete response, excellent radiation and chemotherapy.
For complete response, Nikhil. Okay.
So what I feel is if we have given a cross protocol, then 41.4 gray is definitely not the radical dose for the even if there is a complete response, it's not a radical dose. The chances of relapse will be very high. So I am not sure.
I think Dr. Mandal also seems to be nodding his head in agreement to you.
I fully agree
and
with
okay.
I think
Dr.
what
Nikhil,
I would say, this is too low a dose to consider it as a curative treatment. Though we got some initial response and we are happy about it, but I think this is a very short-lived happiness.
Yes.
Right. What would you do, Dr. Nikhil, the surgeon, in such a scenario?
So same thing, sir. I would if the patient is willing to do the follow-up regularly, I would give an option of wait and watch policy, a regular endoscopy and biopsy. Or if the patient is from a distant place, I would definitely advise him to undergo surgery rather than if doing a regular follow-up and biopsy.
So you would offer them observation. That's what you would say.
Yes. Yes.
Okay. What about the other surgeons, Naveen, Gajanan, Prashant, and Tanveer? Very quickly, would you sort of offer observation at all? Anybody?
It depends on the motivation of the patient. If the patient is an educated, motivated guy, we can offer him, but I will always lean towards surgery.
Gajanan, but offering them a kind of surgery with a dose which is too low, like if it is 45 to 50, I would say no problem. But 41.5 in a cross trial is too low a dose.
Yeah, you're right. That's why we offer. So, see, evidence suggests that local control is better with surgery.
Yeah.
Right. No, but then again, to the purist, you would not know because this assessment you're making a month after giving the 41.5.
Yeah, that's what exactly I'm telling you.
Yeah.
If we have already delivered, if we already delivered 41.5 and after say 6 weeks or 4 weeks, there is no point in adding few more radiation.
Great. That I guess nobody would do. Dr. Mandal and Dr. Nikhil, you won't add anything, right? Even though.
I have a comment to make. If you please. So what I understand is the moment we are following some particular protocol from a trial, it's important to follow the entire trial protocol till the end of the treatment and follow up. The moment we are deviating from it, then ideally we should have a randomized trial to know what actually happens. Otherwise, in this process, we might lose many patients. That's what
So I agree with you. Your point is that you would not offer it to anybody because we are seeing a slightly divided house here, but that's quite interesting. Tanveer, you are very enthusiastic. You want to tell something.
41.4 grays, I would not offer observation. I would offer surgery.
Great. Okay. So
agreed.
You may ask the patient to follow you up, but you have a window period where you may miss disease progression. And by the time I have seen for rectum, I have seen patients who have been offered observation now And by the time they came to us for assessment, it was difficult. It was not possible to resect.
No,
So I would not offer
think
observation.
we've heard the various
And
voices in this, and anybody else wanted to comment quickly?
Arvind, just that I think the concept should be quite clearly gauged right at start of treatment. If the patient's not going to be inclined towards surgery, we give them a radical CTRT protocol if they're going to respond as a squamous CA. But leaving incompletely treated is probably going to be a very high risk for recurrence.
Yeah, I entirely agree. I think that's a larger point. Most of the treatment protocols have to be made upfront. Like when you have started with a protocol of neoadjuvant treatment, then it is paramount that you would have actually explained to this patient that you would be operating him or her in 4 to 6 weeks, irrespective of the response, right? And having said that, I must say that there's a lot of buzz actually going on towards this non-operative treatment, but I must say that it should not be done outside a clinical trial. There are some clinical trials which are ongoing, which are trying to randomize some patients who have had a complete clinical response as well as a radiological response, a very, very intensive follow-up for these patients. And again, as Tanvir said, it's going to be very difficult to sort of, so you would have to sort of, every other month or so, you would have to do them PET CTs, endoscopies, US biopsies, and that's going to be literally impossible in our practice. So if you started off with neoadjuvant chemotherapy or neoadjuvant chemotherapy and radiation, I think for now, I guess it will be preferable to complete the regimen and try to do some form of surgery for these particular patients. Timing of surgery, I think, how long do we have, organizers?
You continue as long as they don't interrupt you.
No, I think
Yes, sir.
yeah, I think.
Okay, no, because I think I'll end it. I think lot of things have been told. I guess Tanvi, anybody wants to comment on these timing of surgery? I think people said 4 to 6 weeks or just around that particular point of time. Approach, I guess minimally invasive should be favorable. Any thoughts on lymphadenectomy? Gajanan, you wanted to say, because you give neoadjuvant chemotherapy, so do you do a 3-field for all your patients?
No, I'm not doing 3-field. I'll be very frank. We are doing 2 fields because the morbidity associated with 3-field is something which is difficult to handle if we do a really proper 3-field surgery.
Great. Yeah, I entirely agree. We follow the cross protocol, and a lot of times, even for patients to undergo 2-field itself, and of course, it all depends upon the age, the comorbidities, the performance.
And actually, I believe that we have not yet shown a distinct advantage with extended lymphadenectomy in esophageal cancer at least.
Yeah, in this setting, post neoadjuvant setting, I guess you have an option. I think residue following neoadjuvant chemotherapy and radiation. Ashish, you want to take this? I think some new buzz coming very last month.
Yes, so like we know, like even just recently we saw the 10 years outcome from the cross trial, and then the absolute benefit in OS was only 13%. Still, like 2/3 of our patients are going to relapse. And especially we know patients who have not had complete response. And so therefore the only thing, and we also know additional chemotherapy is of no use. There's one trial, what you're showing on your screen, Checkmate 577, was a randomized trial of adjuvant immunotherapy. Now, mind you, like this is probably only the second cancer in solid tumors after melanoma where we have seen a positive adjuvant trial. And what the data we have is still only in terms of progression-free survival, but the difference is huge, 11 months versus 22.4. So that's almost like double. And we are hoping that this DFS will actually reflect in OS as well. Maybe next 1 or 2 years, we'll have the data.
Great. I think this trial, I'm pretty much impressed, although it's only a DFS advantage. And as Ashish said, it's doubling of the DFS in such a poor subgroup of patients. That means these patients post-neoadjuvant chemotherapy and radiation, and mind you, these are only for post-neoadjuvant chemotherapy and radiation patients and not for chemotherapy patients. If they have a residue, I think there is some level 1 evidence, and this is come in the guidelines also, the recent NCCN guidelines also, and many other guidelines say that adjuvant nivolumab for about 1 year for some of these patients. Of course, overall data is not mature, but I guess it is pretty good. So I think how many of the surgeons would sort of be consider this practice changing in our Tanvir? Would you refer your patients some of these?
So Dr. Arvind, I would suggest maybe the time is up. So
Great. I think this is my last slide, and and I would like to thank all the panelists. We had, I think, most of whatever I wanted I had conveyed, and I think the panelists have been wonderful. And though there have been 8, I'm sorry because your numbers are too few. I couldn't really get the best out of all of you all, but I'm sure that we could give some takeaways to the audience. And I would once again like to thank Anil, Advaita, and Tejinder for the opportunity to be a part of this wonderful panel. I enjoyed.
Thank you, Anil.
Thank you.
Thanks, Arvind. Thanks, organizers.
And thanks, Arvind.
Yeah, well said.
So, all right, we move on to the next presentation for this session, and this will be a panel discussion on gastric and G-junction tumor. And again, this is going to be a case-based discussion, and the moderator is going to be Dr. Devendra Parekh from Gujarat, Ahmedabad. Dr. Devendra Parekh.
Oh, good evening, everyone. Am I audible?
Yes, you are. You are. Yes, please go ahead.
Okay. Someone has to hold their screen sharing so that I can share my screen. Okay. In the beginning, I would like to congratulate Dr. Advaita and Dr. Anil for arranging such wonderful meeting. And it's a very lengthy topic to include both GI and G-junction tumor. Is a tough task given to me. I will try and do the justice. I guess all of my panelists are on the screen. I'm seeing all 8 of them for surgical oncologists and 2 medical oncologists and radiation oncologists. Quickly going to my presentation. As you can see, it's a 49-year female, a very intellectual patient with perfectly normal performance status, with complaint of dysphagia to solid for only 1 week. And unfortunately, on her upper GI endoscopy, there was a lesion starting from 38 centimeters from the incisor going up to the cardia. Biopsy come motilely differentiated adenocarcinoma. It was essentially a severe type 2 G-junction tumor. PET CT scan was suggestive of T3N+, though not a bulky node. Now, I have a question for my panelists. Are you satisfied with this investigation, or do you want to do anything else apart from this PET CT scan and upper GI endoscopy biopsy? Quickly, anyone from surgical oncology side? Dr. Rajesh, if you can say.
Ideally, I would like to do an staging laparoscopy for this patient, because as you mentioned, it is a type 2 Sieverts. We would like to treat this G-junction tumor on the basis of or on the lines of gastric cancer. So ideally, I would like to go ahead with staging laparoscopy, but in the real world, in a private practice, if there is a PET scan, there is little bit of hesitation to.
So I'll come to that. I agree that according to NCCN, all stage Sievert 2 and 3 has to be taken for diagnostic laparoscopy if they are T3 or N+. Anything else to medical oncologists? Do you want to do any other marker apart from conventional biopsy for G-junction tumor?
So there is some data for anti-HER2 therapy, but having said that, in the neoadjuvant setting, I'm not convinced of their applicability. There is again some data saying that in patients who are MSI high, there is data saying that in these patients, neoadjuvant therapy may not be the way to go forward. These days, I believe in evaluating all my patients thoroughly. So I typically also do an MSI as well as a HER2 in these patients.
Okay, perfectly. So most of the time HER2 is reserved for metastatic setting, but now at our center, our medical oncologist has also started doing MSI and HER2 for such cases. Perfect. So
Done.
To my surgical oncologist colleague, as you can see here, it's a pretty operable lesion with non-bulky lymph nodes and in an excellent performance status lady. Anyone for upfront surgery? No. For Rajesh, Dr. Rajesh, Dr. Nina, Dr. Abhijit, CC sir, anyone? No.
No, we will give neoadjuvant.
Neoadjuvant
So all my panelists agree on one thing, that neoadjuvant treatment is the way forward in such cases. So very quickly to all the surgeons, favor of neoadjuvant treatment.
Yeah, agreed. We have to give neoadjuvant treatment because performance status is good. We would like to give a combination drug, a FLOT4 regimen, which we would like to offer for this patient.
Okay, so you are for FLOT. Dr. Ninad? Is he there?
Yes, I'm there.
Okay. What is your choice of neoadjuvant treatment?
It depends on the medical oncologist choice here mostly. So
okay, but your preference.
Some of them give FLOT.
Okay, so you are also for FLOT. Dr. Sisir and Dr. Rajesh, quickly.
So Devendra, we are talking about a locally advanced cancer, which we're gonna treat like a stomach cancer, and it is important. We got a PET scan done, which is showing that it's not metastatic. The important thing is, like Rajesh mentioned, is that we do a diagnostic laparoscopy, because we have to decide whether we are going to treat it as a locally advanced and we are planning to do the surgery after neoadjuvant chemotherapy, or where the intention of treatment where is curative, or whether we are planning to treat it as a palliative case. So we have to establish that before. So before we start on any regimen, ideally we should put in a scope and see for metastatic, say, peritoneal seedlings or anything.
Yes, that's perfect. That we are agree upon. That diagnostic laparoscopy is the way forward when we are dealing with CVD2 and CVD3.
Probably the way you treat the patient would differ, especially in a T3N1
medium आहे खूप difficult
okay, the point is well taken that almost all the surgeons are in favor of FLOT-based perioperative therapy. I quickly ask the radiation oncologist that what is your take on CVD2 junctional tumor? Dr. Manish, Dr. Sanjay?
It's very different than a normal.
Dr. Sanjay, what is your choice of neoadjuvant therapy?
I think neoadjuvant chemo, I will also prefer FLOT in this case.
I'm not hearing you very properly.
Am I audible now?
Yes, please.
Yeah, even I would prefer a neoadjuvant therapy as an option. I would prefer neoadjuvant chemo rather than CTRT, and I think FLOT is a good regimen for this patient.
Okay. Dr. Manish?
Yeah, I think neoadjuvant chemotherapy is the way forward. But again, chemotherapy is there. CTRT is not the choice of treatment here in the lower GE.
Okay. So here I will not ask medical oncologist, as every other person has asked the patient to go for perioperative chemotherapy. But I really take a look on cross trial, that in cross trial they have said that CVD1 and 2 they try and treat it as esophageal cancer, and only CVD3 they reserve for gastric cancer like treatment. So for CVD2 still you can opt for cross-based perioperative neoadjuvant chemoradiotherapy, but FLOT is perfectly okay. And till this ESOPAC trial comes with the result that whether to give FLOT or cross-based treatment for junctional adenocarcinoma, it's perfectly all right to choose either of them for at least CVD2 classification. So I have one question to Dr. Suhas. How frequently you ask your patient to have chemopod when you ask them to go for FLOT-based perioperative chemotherapy?
So definitely, most of the patient we do request, we do encourage to have a chemoport in the C2 or maybe a PICC line at least, because with the 5FU, we know that with the risk of extravasation and later on complication, it would be very important to have a central venous access in C2.
And Dr. Nilesh, your call on chemoport?
All patients with a chemoport or a PICC line.
Okay. So at our center, as our surgical colleague said, that diagnostic laparoscopy was earlier very difficult for us to convince the patient for diagnostic laparoscopy. But now with the help of our medical oncologists who always emphasize on chemoport insertion, we are able to convince almost entire population for diagnostic laparoscopy and chemoport insertion at the same sitting. And on the very next day, patient go for first cycle of FLOT-based chemotherapy. So in almost 24 hours, we finished three important things: diagnostic laparoscopy, chemoport insertion, and first chemotherapy. So that patient has received perioperative chemotherapy and practically stable disease. There was no progression, but at the same time, there was no response as well. So now, coming back to my surgical colleague, what will be your choice for surgical treatment?
Here, I would like to add that endoscopy, the surgeon has to do it himself, because he has to see the involvement of the esophagus, because that will dictate the kind of approach you will take. Since it is a minimal invasion, so I would do extended total gastrectomy for this.
Okay. Okay. Dr. Sisir? Dr. Ninad, Dr. Rajesh, quickly.
I would like to see the starting of the lesion in the esophagus and the position of the G junction on the endoscopy. Based on that, I will decide whether I will do a transabdominal total. Sorry. Based on the level, involvement of the esophagus, I will take a call whether I am going to do total gastrectomy or a proximal gastrectomy. And the approach again depends on the patient's body.
So what margin basically we are talking about when we are talking about extended proximal or total gastrectomy? In such cases, we are having disease starting from 38 centimeter from incisor. So practically lower thoracic esophagus going into G junction and cardia. So what margin we are trying to aim with extended gastrectomies?
At least a 3 centimeter margin. So the anastomosis will be in the thorax. So
anastomosis will be in the thorax.
So I would like to do the anastomosis via thoracic approach only, because it will be difficult to do with transhiatal approach unless you use a Oroville approach, which is not feasible for our patient population because of the logistic reasons.
So essentially we are talking about here abdominothoracic approach, right?
Or you can do a left thoracoabdominal approach.
Either way, left thoracoabdominal or Ivor Lewis.
Yeah.
Correct. Anyone for minimal invasive surgery? Dr. Rajesh?
I would not prefer in this case.
Okay. So just to give, there is one nice study which says that such cases deserves mediastinal lymph node dissection. For CVAT 1, you have to go above the carina. For CVAT 2, you have to go below the carina, but you have to clear the lower paraesophageal lymph nodes. And that same study said that esophagectomy in such cases, specifically CVAT 2 cases, have better survival compared to extended gastrectomies, mainly because of two reasons. First reason, you will have better margin control. Margin positivity rate will be higher if you will try and do the gastrectomy. Second, you will have better lymph node clearance when you are attempting esophagectomies in such cases. And there is one randomized trial which is going on right now as we are talking, cardiac trial, and we will be able to see the results by 2024, and it will specifically address which lymph node dissection has to be done and which approach is best suited for CVAT 2 junctional adenocarcinoma. These are the CVAT 1, 2, and 3, and according to that classification, CVAT 1 and 2 deserves mediastinal lymph node dissection. For CVAT 3, we can avoid mediastinal lymph node dissection and get away with abdominal D2 lymph node dissection. And at our center, our preference is to do Ivor Lewis esophagectomy for such cases. And now we have shifted to minimal invasive Ivor Lewis esophagectomy. It can be done with either robotic as well as with thoracoscopically. And at the end of the surgery, you can put a nice wound protector and finish the stapling and take out the specimen from this small incision. So that is possible with Ivor Lewis esophagectomy. Good clearance, good margin, and at the end of the day, early recovery because of the minimal invasive approach. Coming back to my second case, it is a pure gastric cancer, distal gastric cancer in 68-year male, otherwise good performance status. no comorbid condition. Biopsy moderate differentiated adenocarcinoma. Upper GI endoscopy says that it is involving the antrum and reaching up to the pylorus. CT scan is suggesting loco-regional disease, no metastatic disease. I would like to ask my medical oncologist that why and how you will change your practice if you have MSI report which says high MSI or low MSI in operable gastric cancers.
So in high MSI in operable cancers, it is always preferred to do upfront surgery. Whereas in stable MSI, you have the option of giving neoadjuvant therapy. The reason for this is patients who've got MSI high do not tend to do very well with initial chemotherapy.
Yeah.
Devendra, sorry to interrupt. I just want to know for my knowledge, how many of us are doing a MSI testing before surgery or before any perioperative
We have
chemotherapy?
to do so. Let me show this.
No, what is the practice? I know
That
this
is what I'm saying, that we
evidence.
have to. So at this point of time, I would like to say that as a surgeon, we need to evolve with our medical oncologist. So earlier, I have seen the hesitancies. If we go back 20 years for breast cancers, our medical oncologists were saying ERPR, HER2, but in 1990s, no one was doing. Everyone was thinking of doing MRM, but now we know that triple negative breast cancer have different survival, and every single surgeon before doing surgery for breast cancer, they will do ERPR, HER2. They will try and find out the molecular diagnosis. Similarly, we are entering in that era that gastric cancer will and have impact by their MSI, their HER2, their PD-L1 and other molecular markers, and gradually that paradigm is already have taken place. So as I was saying, at our center, almost all of our patients receives this molecular analysis until unless if there are any emergencies. And there is nice Petrantonio meta-analysis, as our previous surgeons, medical oncologists were saying that in MSI high subset, there is drastically better disease-free survival as well as overall survival. And this is not the only slide which I am interested in. If you look at this slide, this is excellent slide which is saying that only surgery, this green line saying only surgery in MSI high patient has the best prognosis. If that patient is having MSI high and that patient has received neoadjuvant chemotherapy, they have rather detrimental survival compared to only surgery. So this is something which we have to understand. If that patient is MSI high, by giving neoadjuvant therapy, we are actually causing harm to our patient. So doing MSI is absolutely must. And I guess if I want to give one message to our surgical colleague, that is MSI testing is essential in all gastric cancers. Coming back to this patient had MSI stable disease, and we have planned for, our medical oncologist had planned for perioperative chemotherapy. Now I have a question to my surgical oncology colleague that at the end of perioperative chemotherapy, neoadjuvant chemotherapy, again partial response. There was no CR, and we actually don't aim for CR in such cases, but disease shrunk drastically. So how often, Dr. Rajesh, you will try and take such cases for MIS, either with robotic or with laparoscopy?
Looking at the present scan, it looks feasible for MIS, both ways.
Right.
It will require a radical D2 subtotal gastrectomy. Looking at the scan, although I am seeing only the one image,
correct.
But the pre chemo and the post chemo image, I can see clearly the fat planes between the pancreas and the stomach. Duodenum, first part of the duodenum appears normal. I cannot see any haziness or loss of fat stranding around the gallbladder also. So I think this is an ideal case for an MIS.
Excellent.
But I would like to see the entire scan.
Yes. So I'm agree with you that you are in favor of MIS if it is a clear-cut operable case without any unfavorable features on scan.
Particularly for the distal tumors.
Agree. Point well taken. Would you like to evaluate the distal margin for frozen section evaluation in
Yes.
distal gastric cancer?
Yes, always.
Always. And what if it comes positive?
Then I would like to revise. I can go up safely. I can safely excise up to the entire D1.
Correct. Any experience of gastrovipal for distal gastric cancers?
I personally don't have.
Okay. Any of
But
my
that is
panelists?
also possible. We when I was in Tata, we had done certain like 4 or 5 gastrovipals, but those cases we did not do it for the positive margins. We did it because outside elsewhere they were stented.
Okay.
Because of the gastric outlet obstruction, they were stented. So we didn't have a choice, and that was not an on-table surprise. It was a planned gastrovipals. That also makes a difference because in that cases you are sure about the fitness of the patient and all.
Right. Okay.
For the margins, I have not come across.
Yeah, for margins, usually you can even have like a pancreas head preserving, like D1 up till junction of D1, D2. We can
Resection of D1. Yes,
so
yes, that is
usually
possible.
people will never be required.
And what after taking the second margin? Will you again send it for frozen section once? And second time, once we resect the margin, we don't send it for frozen. And if it turned out positive in final report, then we blame the tumor biology. So that's how we practice. So I just
I'm sure almost everyone does that.
Perfect. Okay. So swiftly coming to my third. Before just we have already discussed this, so I am not going in detail of this class and JCOG trials, which have shown the benefit of laparoscopic gastrectomy compared to open gastrectomy with similar DFS and OS for both early and advanced gastric cancer. So will not go in detail. So coming back to third case, as you can see, there is a long segment junctional tumor, and such cases are not infrequent when we are talking about our continent. So I have question to our medical oncologists that apart from conventional perioperative treatment for such non-metastatic disease, anything else you would like to add if that patient is having HER2 positive or
So HER2 positive, there is the option of adding trastuzumab, but in the neoadjuvant setting, it has not really turned out to be very useful. There is some data about the combination of using pertuzumab with trastuzumab along with chemotherapy in these patients who are HER2 positive. But again, those are initial days, and we don't use it in all patients. But that combination is something that is feasible. Also, if somebody is MSI high, I would be tempted to consider an immunotherapy agent in somebody who's got such an extensive disease.
Right.
Again, there is no data as of today for that.
To my surgical colleague, at the end of perioperative neoadjuvant treatment, if this patient comes to you, how you will like to treat this patient? Which approach and what surgery?
This is a challenging case because we have seen there's a lot of esophageal involvement. So we have to do something like subtotal esophagectomy. Moreover, the proximal stomach is also involved. So you need to, maybe we'll not get the reach to do a thoracic anastomosis. So we will end up with a complete esophagectomy and gastrectomy. So then we have the alternate conduits like either a jejunal conduit or a colonic conduit. So these are the two reconstructive options. But we have seen these kind of patients who have long segment disease, they behave very aggressively. And you will find invariably, you will find that there is some metastatic disease somewhere. So most of them turns out to be unresectable. Moreover, nutrition is a very important factor in these cases. We find that these patients to give, they will default, easily they will default. These patients usually
So as
default.
you can
So we
see,
need,
this particular patient was a doctor. He is a real patient and he had no weight loss. So he presented to us and he had dysphagia for only 4 days. And to all of our surprise, we seen a disease which was probably the lengthiest disease we have ever seen at the junctional area. And
this is a common scenario we see for squamous cell carcinoma, where you have a lot of esophageal involvement with involvement of the proximal stomach. So these are very aggressive disease. Very seldom they will come to your operating theater.
So esophagogastrectomy are the preferred choices for such cases. And if at all we have to perform surgery, we have to be prepared with the colonic transposition in such cases.
So you
that
need
was
a
the
pre-op colonoscopy to be done for these patients.
at least colonic preparation. Coming back to fourth question, and this is very common finding that for young female patient with signature adenocarcinoma, when we do diagnostic laparoscopy for advanced disease, we see this picture, peritoneal metastasis. I have a question for Dr. Ninad, as he is an excellent CRS HIPEC surgeon. Sir, can you elaborate on this, that if you see such a picture on diagnostic laparoscopy, will you keep the option of cure in your mind when you would further explain to the patient? If yes, what will be the cutoff PCI you will aim for to achieve cure, and what will be your strategy? Will you straight away go for CRS HIPEC, or you will like to give some form of neoadjuvant chemotherapy and then go for actual surgery? Dr. Ninad.
Yeah, so firstly, young patient signet cell with a peritoneal metastatic disease is usually going to do badly. So I'll be a bit pessimistic in her. But usually if you have a case where peritoneal disease is present, we have a low threshold in stomach cancer. The PCI, some studies have quoted till 12, but in my personal experience, what I've seen, a PCI of 6 to 7 is the one which has responded to neoadjuvant chemotherapy. We still don't routinely use IP chemotherapy, but all the Japanese and Singapore studies have shown that IP chemotherapy works usually in a low volume disease. And these patients do get converted at a later date for the CRS HIPEC. So if it's a low volume disease with a PCI around 5-6, I will think from a cure perspective, but otherwise it will be more from palliation.
Okay.
So anecdotal case, if they respond really well, say a complete response in the peritoneum, I'll still take multi-quadrant biopsy, confirm that it is like there is a fibrosis, there is the disease has destroyed definitely. Then
okay. I have a question for Dr. Nilesh, Dr. Suhas, that now in such scenario, here we are talking about metastatic gastric cancer with peritoneal metastasis. What will be your choice of neoadjuvant regime? If at all your surgeon says that probably he will go for CRS HIPEC later on.
So I think this is a patient who I'd like to work up a little more from the point of molecular markers, both the PD-L1, MSI, HER2, and if possible, even a broader NGS panel. Apart from those targeted therapies, if I were to talk about basic chemotherapy, there has been a lot of data initially about the 3-drug regimen, but in my preference, I understand that this is a situation where we typically sequence therapies multiple times. And I would be more comfortable using a 2-drug regimen, either a FOLFOX6 or a CAPOX-based regimen. If the HER2 is positive, I would definitely like to add trastuzumab in that. If MSI is positive, then we have data for single-agent pembrolizumab in this setting. And this is for the first line. In subsequent lines, you have drugs like paclitaxel, ramucirumab, and many others.
Okay. And at the time of doing CRS HIPEC, which chemotherapy agent would you like to administer in intraperitoneal chemotherapy?
So my experience has mainly been for ovarian cancer, where it's been cisplatin and adriamycin. I think Ninad will be a better person to guide regarding this.
Dr. Ninad.
So here the drug of choice is mitomycin. I prefer mitomycin because that is one drug which the tumor is never exposed to in IV regimes, and in HIPEC, the potentiation of the drug and efficacy both has been seen is pretty good. Other option which we have also used in stomach is a combination of cisplatin and adriamycin.
Okay.
So usually when my boss in France, what we used to do is that time they used to give ECF as a neoadjuvant regime. So if there was a very good response to ECF regime, they used to consider giving cisplatin adriamycin as the IP chemo drug also. And if they used to give Folfox, then they used to use oxaliplatin. But what oxaliplatin does is there is a very high risk of post-op hemorrhage, and the complication rates are higher. So we are gradually shifting to mitomycin.
Mitomycin. So at present, mitomycin is a drug of choice. Dr. Suhas, any comment?
Same, I think Dr. Lokeshwar has rightly said. So we can consider for HER2, MSI, and the PD-L1 testing in addition to that.
Okay, perfect. So coming back to my last slide. Gastric cancer with gastric outlet obstruction. We have only CT scan. Very swiftly, I want to ask all my surgical colleagues, surgery versus stenting. This patient is due for endoscopy. What you will advise to your medical gastroenterologist?
No stenting.
No stenting.
No stenting.
Okay, okay. That is interesting.
This patient might be operable of all,
It is operable. Most of such cases are operable. Yes.
Most of these type of cases.
Most of these outlet patients, you will find a small tumor in the antrum which is blocking.
Yes.
So invariably they will be operable.
So why do you want to make an operable into an inoperable case?
Absolutely. So point is well taken. Stenting versus surgery. It is always surgery. It is always good to rehabilitate such cases because they have some form of electrolyte imbalance, and it is essential to treat those situations before we jump onto the surgery. Coming back to the last question, and I have a question for my radiation colleague. A patient having body mass lesion, broad-based tumor on perioperative chemotherapy, essentially neoadjuvant chemotherapy, have continuous chronic blood loss and having continuous loss of hemoglobin, and at the end of second cycle it's 5.6. Would you like to give hemostatic radiation in between the chemotherapy?
Sir, we request you to please conclude in next 2 minutes.
Yep, this is the last slide.
Yeah, definitely HB is dropping after your second chemo in 5.6. Your definitely GC will be bad. So give PAL-RT as a hemostatic RT and then control the bleeding and then continue further treatment.
So why you use the word PAL-RT? Because so now we have seen this at our center also, that even if that patient is for curative setting, we are planning neoadjuvant chemo followed by surgery followed by adjuvant chemo, and in between if patient is having bleeding and we are considering hemostatic radiation, why you consider it as palliative radiation?
See, your plan is already fixed. Your plan for neoadjuvant chemo. You cannot introduce radiation in between and say you're going to change your plan and do neoadjuvant CT-RT. So
the
just
word is hemostatic radiation, hemostatic RT.
Hemostatic RT to control the symptoms, control the bleeding. You don't give it like a curative setting. It's only 5 fractions.
Yes. So what is your preferred regime? There are 3 regime, I guess.
I would prefer.
What is your preferred regime?
20 gray and 5.
5 fraction 20 grays.
Yes.
Okay. Dr. Manish? I guess Dr. Manish is not there. Okay, so this is a real patient where our radiation oncologist has given single fraction 8 gray, and that patient had requirement of 2 PCV even after the hemostatic radiation. But fortunately, at the end of that radiation session, he had uneventful another 2 cycles of plot-based chemotherapy, and subsequently he underwent surgery. So thank you to my panelists.
I just have one question, Dr. Devendra. I just want to
yes.
I just want to ask you about the slide which you showed where MSI high, you don't give perioperative chemo. How many actually follow that? Because we see in our center all locally advanced do get neoadjuvant chemo as the preferred modality and then get operated.
So we are talking about this.
Actually, this is some new data that has come up.
Yeah,
Having
exactly.
said that, for a long time we've not been actually testing patients for MSI. Since the advent of this data, most of us have started doing that.
This is from which data? Which trial is this?
I'm not sure about the trial, but I did look it up.
Let me show
No. Let me
this
tell you,
is
Devendra.
meta-analysis. This is a meta-analysis.
Retrospective data. This is meta-analysis, but the retrospective data from the pre-operative treatment protocols in gastric cancer.
Absolutely,
Number of
absolutely.
equipment in individual study is small. This is the retrospective analysis. They have done the MSI testing on these specimens and found that basically the findings. So it is over 3-4 years and found that the perioperative chemotherapy doesn't make much of a difference in these subsets of the patients. So this is no prospective data.
Absolutely, but this is a area where prospective trial is very difficult. If I ask all the medical oncologists, what is their MSI high percentage in your gastric cancer patient, Dr. Nilesh?
5%.
Exactly, it's not more than
Only
5%.
in G junction. In G junction, it goes up to 15%, but in stomach, body, and upper esophagus is 5%.
It cannot be more than 5-7%. So the idea is this, and this study has evaluated the results of MAGIC trial, and which one is the other? I, as a surgeon, it's very difficult for me to remember this. Classic trial.
MAGIC, and this
Classic.
So and if you heard the Dr. Janjania from MSKCC, she is openly saying that she has stopped giving neoadjuvant. In fact, neoadjuvant is causing more harm to your patients. And now there are a lot of centers world over who have shifted their practice from neoadjuvant chemotherapy when they are seeing MSI high patients. So yes, it's a new thing, and gradually we are shifting to this area also. So
I think we can conclude it here.
Yes, this is the take-home message, and I am thanking all my panelists and the organizers for giving me this opportunity.
Yeah, thank you. Thank you, Devendra, and thank you for the excellent panel, very lively discussion. Thank you, Dr. Atul Sharma, for chairing this session. I thank all the participants, all the panelists, and all the senior experienced faculty who, for this first day of this GI review. We have 3 more days to go, and taking each subspecialty of GI into consideration. And I hope each day will be as exciting as this one. Please do join us for the next 3 days. Thank you very much for supporting this.
I thought Anil is inviting us for drinks now.
Yeah, the invitation
I was
is
just thinking, where are the drinks now?
The drinks will be directly provided to you.
Directly.
At your own cost.
Okay,
At your own cost.
Anil is telling me, okay, you can go ahead and have your drinks and dinner.
I know. Shishir, sorry to bother you on Friday evening.
So another thing I would mention that this was also beamed on SFS website, that is Surgeons for Surgeons, which was hosted by Dr. Parul Shukla from Cornell, New York, and he has they have also supported this GI review. So there were people watching you all across the globe on the website.
Not the correct time to talk about drinks.
Great.
Sure.
So
you can share your drink with everybody across the globe at whatever time they were.
Fantastic.
Anil, we are not going
to Parul, so.
Anil, we are not going to leave you like this.
Sure.
Once leave you like this, one day we're going to catch you.
Yes, it will be on me.
Yeah. Okay. Nice. Thanks, Anil.
Thank you, everyone.
Thank you, everyone. Thank you.
Thank you, Dr.